Dr. Armandeep Singh Olak, who will be presenting on carotid plaque characterization using plaque RADS, correlation with symptomatic status and post-stenting diffusion findings.
Okay. Good morning, everyone. I shall be presenting our prospective study on carotid plaque characterization using plaque RADS and its association with symptomatic status and post-stenting DWI findings. So, as we know, stroke is one of the leading causes of global morbidity and mortality, and carotid stenosis, the extracranial carotid stenosis, is responsible for around 20% of the cases. Now, the atherosclerotic disease per se is a biologically active disease, and the plaque keeps evolving as it grows. The current guidelines recommend revascularization in symptomatic carotid disease of more than 50% stenosis or asymptomatic of more than 70% in certain situations. But the problem is many strokes arise even in mild or moderate stenosis plaques. And in the recent times, the plaque vulnerability has gained attention, and there are multiple features associated with the plaque which are independently related to the stroke risk. And that is why plaque RADS has been suggested as a framework to shift the focus from degree of stenosis alone to incorporate plaque vulnerability in the evaluation. Our objectives were to characterize the plaques using CT angiogram, which is already being done routinely, and additionally a plaque MRI, and classify the plaques using plaque RADS. We also evaluated the patterns of infarct in symptomatic carotid disease patients, and of the subset which underwent stenting, we evaluated pre and post DWI lesions. So these were our inclusion criteria: any symptomatic carotid stenosis patient, and we excluded non-atherosclerotic carotid disease patients. And the essence of the study was the plaque MRI, which was done on 3 Tesla machine using MPRAGE and T1 FATSAT sequences to evaluate the neck and DWI brain and TOF to evaluate the vessels. The sample size was 71, so it gave 142 carotid arteries to be evaluated. The parameters used in the study mainly were degree of stenosis based on ACID criteria. We evaluated the CT plaque morphology based on the calcification pattern. Also, the plaque RADS categories were assigned. The brain infarct patterns were classified into watershed, territorial, or embolic. And of the subgroup undergoing stenting, the DWI imaging was done 24 hours after the procedure. And all the patients underwent carotid artery stenting with the adequate antiplatelets, statins for plaque stabilization, and no EPD was used in the study. This is the plaque RADS category. To simplify, it basically tells the evolution of the plaque. Plaque RADS 1 is a normal wall, plaque RADS 2 is a thickening of the wall, and based on the thickness, we move on between 2 to 3. After 3, we start incorporating multiple features like lipid-rich necrotic core, the thickness of the fibrous cap, and the ulcerations in the plaque. So based on these findings, high-risk plaque RADS is classified as 3 or above in recent studies. This is the calcification pattern which we used to classify the plaques, type 1 to type 6. The type 6 specifically has a positive rim sign which has been associated with high-risk features. And these are the patterns of infarcts which we used. Coming to results, of the 142 arteries, half of them were assigned to the symptomatic side. The mean age of the patients was 63, which is concordant with the available literature. 49% of the arteries had severe stenosis, and 68% of them were symptomatic. Near occlusion as a separate class was having much more proportion of symptomatic patients. But the point to note is that 32% of symptomatic arteries had mild to moderate stenosis. And among the mild stenosis patients, plaques, 24% were already symptomatic. Among the moderate stenosis category, 64% were symptomatic. And bilateral carotid disease was present in around 30% of the patients. So our cohort was a high-risk group. So, among the CT plaque morphology, specifically the type 6 plaques, are almost more than 75% of the type 6 plaques were symptomatic. And around 70% of type 6 plaques had intraplaque hemorrhage. So this showed high concordance with high-risk features on MR. 66% of high-risk plaques were symptomatic, which were defined based on the plaque RADS categories. and which had higher odds of symptomatic presentation. In the moderate stenosis group, high-risk plaque rats was seen in 80% of the symptomatic arteries compared to 33% in the asymptomatic group. To simplify, this is the comparison. Total number of plaques in the mild to moderate group were 50. Almost 50% of the mild to moderate plaques were symptomatic. 35% of the symptomatic plaques had an IPH, and among the plaques with IPH, 72% were symptomatic. So specifically in the mild to moderate subgroup, the plaque vulnerability features are correlating with the symptomatic status. Among the severe stenosis group, 68% were symptomatic, which are expected based on the current knowledge about the plaque disease which we have. And 50% of the plaque had IPH. 73% of the high-risk plaques were symptomatic. On multivariable analysis, high-risk plaque, IPH and severe stenosis were independent predictors of the symptomatic disease. And it was IPH was significantly more prevalent in the symptomatic arteries in all the groups. But another point to note is that almost among the severe stenosis plaque, 55% did not have IPH, which shows that severe stenosis is not synonymous with hemorrhagic plaque instability, and both the mechanisms go parallel. Among the infarct patterns, watershed was the most common pattern. Rest of the patterns were heterogeneously distributed, and the significant distribution was not achieved in any of the plaque features, which suggests that the pattern of infarcts is more of an hemodynamic phenomenon than the plaque biology alone. Among the post-stenting group, we had 32 patients undergoing carotid stenting, and 7 of them showed post-stenting DWI lesions. All of them were clinically silent and were not associated with any of the plaque features discussed earlier. In discussion, the carotid plaque vulnerability markers, specifically IPH, high-risk plaque rats, and high-risk CT morphology, which is the type 6 plaque, they consistently identified symptomatic disease. This supports a shift from stenosis-based plaque risk to stenosis-based risk stratification to plaque-based risk stratification. The degree of stenosis is important, but it gives an incomplete picture. 1/3 of the symptomatic arteries had only mild to moderate stenosis. Now, since MRI is not available everywhere, type 6 plaque morphology on the routine CT angio has strong correlation with IPH, which can be used as a surrogate marker for IPH. And it is also pertinent that once IPH is present, it is associated with symptomatic status irrespective of the stenosis. Now, we also saw that there were plaques which did not have the vulnerability markers, which were already symptomatic. So this shows that there are multiple mechanisms of symptoms in carotid artery disease. The degree of stenosis leads to hemodynamic phenomenon, and the embologenic plaque biology is represented by the vulnerability markers. Among the post-stenting group, the DWI changes were essentially silent and were not associated with the plaque morphology. The clinical implications of the study are that the stenosis alone may underestimate stroke risk, especially in the mild to moderate stenosis subgroup. And it is even more valuable, especially in this group, that patients who are clinically discordant with the stenosis category should be evaluated for the plaque biology. In conclusion, in moderate stenosis, high-risk plaque rats and IPH show strong association with symptoms. MRI detected IPH was more prevalent in the symptomatic groups and independently associated with symptoms. CT, angio, type 6 morphology and IPH show good concordance and can act as a surrogate marker. The brain infarcts are heterogeneous, and post-stenting DWI lesions are infrequent and clinically silent in our group. These are the limitations of my study. Thank you. Thank you.
Do you compare ultrasound score, CT score, MRI score for rats?
Yes, sir. The plaque rats incorporates multimodality imaging, but in this study, ultrasound was not included to let go of the inter-observer variability. We wanted an objective criteria, so we have not used ultrasound. Also, it gets affected by bilateral disease and many other factors, so ultrasound was not included in this group.
So, in all cases, CT and MR both rates are taken?
Yes, sir. CT angio and MR angio with specific sequences for the plaque.
So is there any discrepancy in RAD score on CT and MRI?
Sir, actually the RAD score has, if I go back, the RAD score has multiple components. Some of them can be picked only on MR. Like CT angio is not validated as strongly MR imaging findings, especially the MP-RAGE sequence to pick up IPH. So the most important marker is IPH, which is picked up definitively only on MR at present, and it has been validated with histology. So on CT, we have other markers like ulceration, the plaque irregularity, degree of stenosis, which is a part of plaque RADS, but other features like intraplaque hemorrhage. On CT, we pick the interluminal thrombus. So there are few factors which are there on CT angio and few on MR. So a combined picture gives us a plaque RADS. Thank you.
So our next presenter is Dr. Vivek Srikanth, who will be presenting on iatrogenic arteriolymphatic fistula following femoral access for coronary angioplasty, presenting with acute kidney injury, a rare complication, and a review of literature.
Good morning, respected seniors and my dear friends. I'll be presenting on the iatrogenic arteriolymphatic fistula following femoral access for coronary angioplasty, which was presenting with acute kidney injury, a rare complication, and review of literature. So this was a case history. 70-year-old male patient who was presented with a history of he was having coronary artery disease post PTCS stent was done to LCX in 2006 and in RCA in the 2012. History of diabetes mellitus, and he also had undergone commando neck dissection, that is combined mandibulectomy and neck dissection for the oral CA. And coming to 2024, he had a coronary angiography which showed RCA instant restenosis and a branch vessel disease. For that, he underwent a post-PTCA stent to the RCA and Optis marginal. This is, I'm just giving the timelines here. This was done in first week of August. And again, the cardiologist did for the right ICA stenosis. 1 week later, he did carotid artery stenting as well for the same patient. And the patient was a doctor and he was a senior cardiologist's batchmate, in fact. So this is what was the history, and the very next day after the carotid stenting IR reference was given, the patient complained of severe pain abdomen. So I was called to see if there is a retroperitoneal collection or a retroperitoneal hematoma. He was in the ICU, cardiac ICU, for the feasibility of drainage of the retroperitoneal collection. And USG was done, which showed minimal retroperitoneal fluid. There was no hematoma at this point of time. So I just told there is no retroperitoneal fluid, and he was complaining of pain. So the ongoing abdomen pain was there in the next 24 hours. They suspected if there is any pancreatitis. So serum amylase and lipase was normal. However, his urine output reduced and he became anuric in the next 24 hours. Serum creatinine increased, shot up to 2.2 within 48 hours of carotid stenting. And he was in ICU. He underwent 1 session of hemodialysis. At this point, CT scan was advised. So this was the CT plain. Because of his high creatinine, just first the plain CT was done. There was no retroperitoneal hematoma, but there was significant retroperitoneal inflammation, and the perinephric inflammation was there in this plain CT. But if we look this CT carefully, we are seeing this some soft tissue which is there in the retrocrural and the prevertebral region here. And at this point, after the dialysis, he was again sent for the contrast CT. As we can see here, in the contrast CT, there is a significant retroperitoneal inflammation. IVC has become slit-like. The renal vessels have become compressed, and this was there. But as we come to the groin here, we are seeing an interesting finding where there is an enhancing lymph node with the multiple serpiginous and linear dilated channels in the right groin was seen. At this point, even we were not sure. We were seeing this for the first time, and just went and saw the literature. And there is only 3 cases reported, and I think 2 are from our own society. I'll just come to that later. So at this point, there was an arteriolymphatic fistula was our diagnosis which we made, looking at these things, these serpiginous enhancing structures from the right groin which were ascending upwards. But there was no thoracic duct or cisterna chyli was not enhancing here. Welcome. So this was the review of the literature, which was one by CMC Vellore and another one by Dr. Preetham Chatterjee. So this was where they had done a glue embolization for one case, and another one was very interesting where it caused a spontaneous swelling in the left supraclavicular region. But in both the cases, we saw this sort of similar image was there, but they also had an enhancing thoracic duct in both the cases were reported in these 2 cases. And there is a third case which was reported by the US where they had an right lower extremity swelling was done. In these three cases, one was done by glue embolization by selective cannulation of the artery, and in the left supraclavicular swelling, just an USG guided compression was done and the fistula went off. And in the third case in the US, they did a open surgical repair. And in the literature, went to the literature again, there were two cases of aortolymphatic fistula between the aorta and the cisterna chyli were reported. One was during the open surgical repair for aneurysm and another one during the EVAR. So these were the 5 cases which were reported in the literature I could search. And okay, now we discussed with this thing, and we did the conventional angiogram, and this was the reason I think the thoracic duct was not seen, because it was all going into the venous side. Half of it was getting into the venous side, then took back into the common femoral and did one thing where we can see the enhancing lymph node as well from the contralateral axis. So both the venous and the lymphatic communications were from the SFA. At this point, we called the vascular surgeon also, because the son was an intensivist in US. He is a doctor himself, but the surgeon was not willing to operate at high creatinine. He was in the ICU and all. At this point, this was a SFA communication was there. A covered stent was placed in the SFA, 7 into 37 mm stent was placed in the SFA, and this was the post-stent angiograms where both the arteriolymphatic and the arteriovenous fistulas were closed. And the next in the post-procedure, within 24 hours, his serum creatinine reduced to 1.1, and he was discharged after 48 hours. But the patient's things didn't end here. He again came to ER with a lower GI bleed. This was so much of one ulcer was there in the ascending colon, and he came to the ER, and this was the bleed which was there. And again went in the night and did a selective embolization of that ascending colon branch, ileocolic branch. And we got, because of that, the CT was done, and we can see the CT pre and post procedure. We can see the significant reduction of the inflammation in the retroperitoneum. Even the IVC has become normal in size. And we can see that this was a 10-day post CT due to that embolization. We were pre-embolization CT, and we can see this stent here, and the lymph node has come to normal. So these were my take-home points. Arteriolymphatic fistula is a rare complication following femoral vascular access. Doppler ultrasound and CT will become important in detecting this rare complication. We were seeing that this is the 4th case which we have seen, and in our case, retroperitoneal inflammation which caused compression of the renal vessels led to the acute kidney injury and the secondary organ damage. And management is tailored in one selective embolization. If we can do that, that would be the best, and ultrasound guided compression, and it depends on the flow dynamics and the anatomy of the fistula. Thank you.
I have one question. You thought of putting a covered stent.
Yes, sir.
Would you say this is an ultrasound?
Sir, ultrasound was done it was only, there were a lot of channels were seen in the ultrasound. We did the groin ultrasound at that point of time, but there was so much inflammation and so much of enhanced lymphatics and all those things were done, sir.
There was only one tributary which was coming from the SFA.
So it was not a tributary, sir. It was directly with the arteriovenous fistula. It was a direct rent of hardly 2 mm in length, sir. So in that way, we thought whether we put a coil, but we were not sure. We thought coil or anything will just fly off into the venous side. So at that point, again the SFA, because we are below the joint, across the joint, we were in the SFA. We thought we will place a cover stand, and we got a 18-month follow-up. So he's still doing okay.
Age,
But
age.
70 years, 70 years he's.
Next present is Dr. Jinesh Velakada sir, who will be presenting on pseudocontinuous ASL perfusion as a predictor of wound healing in diabetic foot following IP balloon angioplasty, a prospective single center cohort study.
Good morning. So my topic is the role of ASL in diabetic foot wound healing. That's the crux of that study. So the background is that these are cases of infrapapillary angioplasty, and we know that these patients are completely diabetic patients. So there are multiple predictors of wound healing in such patients, and these patients have poor glycemic index, extrinsic calcifications, and neuropathic ulcers. So it's very difficult to predict whether the ulcer will heal, and it's difficult to tell the patient when the ulcer will heal. So there is an international food guidelines are there, and 23 guidelines clearly tell that there are issues with the revascularization beneficiaries who will benefit with revascularization. ABPA, toe brachial index, Doppler, etc. are not a good predictor for wound healing. So they told that there is a need to identify a tool which will be good to predict a wound healing, and with that background we went the study to do the results of ASL, that is arterial spin labeling, that is extensively used in brain, but it's very difficult to do in foot and lower limb because you cannot tag that in the direction caudally. So we broke that cord in the MRI and give the tagging in that other direction. So we just look for what is the prognostic value of that perfusion parameter, which is a completely non-contrast angiographic perfusion parameter, to look for the wound healing. So these are the inclusion criteria. They were purely solely diabetic foot ulcers with infrapopliteal disease, only infrapopliteal disease without neuropathic ulcer. And so the approval was obtained, and we did pseudocondylar's ASL. That is from the foot, from the knee joint, we tagged that blood cells and took the pseudocondylar's ASL. And over a time of 3 to 4 minutes after giving sedation to the patient. All these patients underwent angioplasty. So this was a cohort from 238 patients with diabetic. 50 of the exclusion criteria, fulfilling the inclusion criteria and excluding criteria, 58 patients were taken, and angioplasty was done pre and post. And we studied that what are the predictors that, and this was the demographic parameters, which was nothing special. And the investigation showed that angle pressure index and Wi-Fi scoring, so that the range was almost in the range of 1.2. That's slightly in the lower end of the Wi-Fi and ABPA scores. And we did the pre and post angiogram ASL, and there was a significant increase in the perfusion, the pre and post ASL. And in all parameters of ASL, there was a significant increase in the perfusion in the hind foot and forefoot. And we looked for the patient, we followed the patient whether the wound was healing or not. So we took the parameters, which are the parameters that predicted the wound healing. It found that if there is a CKD and there is a Wi-Fi score is in the higher end, and also there is a complete pedal arch were reconstructed, there were early wound healing, whereas angiosome-based reconstruction, there was no difference in the wound healing time between if you do angiosome-based or non-angiosome-based. And among the MRI parameters, if the pre-ASL, that is pre-procedure ASL perfusion is low, that means that those patients would have better wound healing. And percentage gain also had univariate regression, had predictors of wound healing. But we did multivariate regression coefficient for this wound healing in months and found out that two main parameters, that is Wi-Fi stage and pre-procedure ASL for perfusion, these were the independent risks of wound healing. So we derived an equation. We can predict when the wound will heal, and we got an equation that 0.78 the ASL foot perfusion ratio minus Wi-Fi raised to minus 2.3. That is the time in which the wound will heal in future. So we can tell the patient that with this score, pre-op itself, we can tell the patient that the wound is likely to heal in this much time. So this was a patient, we use routine do non-contrast MRI angiography and bless this ALC sequence, do the angioplasty and do post-ASL, and we can counsel the patient that his wound will likely to heal in this time. So the limitations that the sample size is limited, it's for 58 only, and we didn't do a DSA perfusion because DSA perfusion is contrast intensive, and MR and CT also, in the angiogram also you can only do 2D DSA, 3D DSA cannot be done. The strength is that its ASL is not described prior in foot because you cannot tag that foot in reverse direction, you can only tag above that level. So it's not described elsewhere, and it's a homogeneous population. It's a uniform regular follow-up. All patients were regularly followed-up, and it's an equitable distribution. So the conclusion is that ASL is reproducible, and it's an objective technique for measuring the pedal perfusion. And it can show that increase in malleolar perfusion, and it can also predict the wound healing. You can, by the ASL perfusion ratio and Wi-Fi score, with these two scores itself, we can predict that the wound will heal in a particular time period, and it will be better for diabetic patient. And then other spin-off from the study was that angiosome revascularization was not a good predictor. Thank you.
In these all cases, 2D perfusion was taken or not?
Not taken.
Of the miscellaneous and non-vascular intervention series. So we thank the jury for their taking their precious time out to help judge. We also thank all the participants for their wonderful presentation.
Finished gym, right? I went for a drink and was being greedy. I ordered 2 drinks. And one nice Americano with that little straw, a small straw, standard size. I also ordered this acai mango smoothie, which is very yummy, but it's got large mango bits in it. I had to use this large straw or catheter in our case today, right? So I realized then you truly need a purpose-built device for the purpose you are doing. If you're sucking out something chunky, you need a large bore catheter. And I think through this talk today, I want to try and convince you or whoever who is around here today that large bore mechanical thrombectomy is truly the way to go for acute PE. I have nothing to disclose. Instead of telling you the step-by-step procedure and the data out there, I thought I'd share with you the Changi Hospital story. We are from Singapore. We are in the eastern part of Singapore near the airport, and you would think and you would imagine that we will have a lot of acute PE cases, and we do have. We are 1,000 bedded hospital, 24/7 IR service, 1 biplane, 1 hybrid CT room. And just before I start off the history, just to set the scene, currently in this day and age, we divide PE into several categories. Of course, we divide them based on how fast and how likely the patient is going to die from PE. So you can either call them previously massive, submassive, non-massive, depending on the cardiovascular status, or high to intermediate high risk groups. So these are truly the groups that will kill the patient if we don't actively intervene. So previously, before 2022, when you have a large central PE straddling the main pulmonary trunk to bilateral pulmonary arteries, and you have some evidence of right ventricular dysfunction, what do you call those? You call those an intermediate high risk or submassive PE, right? And the only treatment available at that time is anticoagulation. And how does anticoagulation work? It doesn't dissolve the clot. It works by preventing further clot propagation so that your own body's lysis system can work. Now, it takes some time for your own body's lysis mechanism to work, and in the meantime, you can only pray. You can pray that the patient survives this and not get worse. Now, if the patient gets worse, if his BP starts to drop, if he requires some form of resuscitation, you call this high risk or massive PE. And we know that 5 to 15% of intermediate high risk PE patients will progress to this. Now, in this case, you need something a little bit more aggressive. You need to accelerate the lytic process, so people add on things like systemic thrombolysis. And actually, that's the only thing you have, systemic thrombolysis. And it is an emergency reperfusion attempt. So then you double pray. You pray that the patient, during the infusion process, during the 2-hour, 6-hour, 12-hour to 24-hour infusion, the clot will dissolve in time. And you also pray that the patient doesn't have a severe bleed, most significant of which is the intracranial hemorrhage during this period in time. So unfortunately, we know that thrombolysis works, but it doesn't work so well. And it gives us several complications. We do have quantitative studies for that. Angiographies of post-thrombolysis patients show that 80% of the clot remains after 2 hours. More than half remains after 6 hours of infusion. So what is PE treatment? PE treatment is, is fighting against time because the heart is constantly pushing against this clot. It is chasing time till enough clot dissolution versus the time till the heart gives up on you, right? So chemistry-based treatment success is really time-dependent, and time is not on your side. So then what is the role for IR before 2022? It is really, we are called upon as a last-stage effort to accelerate clot dissolution, whether the patient is deteriorating or the patient is unable to get thrombolysis. So then we do things like catheter-directed thrombolysis or mechanical pharmacomechanical thrombolysis using various non-dedicated, non-purpose-driven small caliber devices. So fortunately for us, we have very few of these, probably about 1 every 2 to 3 years we were called upon. And since this patient got onto the newspaper, you know that he came out alive. So that was the time we used this humble pigtail catheter to disrupt the clot. So different centers around the world during that time used different catheter-directed thrombolysis and fragmentation techniques. For me, I prefer the pigtail catheter. Some use the McNamara catheter infusion fibrinolysis, direct lytic fibrinolysis of the clots by direct penetration into the clot. Some use the ultrasound accelerated technique, and that is the ECOS catheter. So it sort of improves the penetration of the lytic agents. But despite that, over the past 10 to 20 years, until 2022, we are not seeing any improvement in acute pulmonary embolism survival, especially for the massive group. A lot of them are dropping and dying in front of our eyes. So then we see an unmet demand, And we're looking for a really effective PE device. So what does that mean? We want something that can unload the right ventricle as fast as possible, as much as possible, and as safe as feasible. So of course, if you are looking at the first two, you want en-bloc removal of the central clots instead of just fragmentation. You want immediate clinical outcome improvement. You want to have no question about any significant residual clots as you go back home from the procedure. And you want it to be as safe as possible, i.e. an equal or better safety profile compared to smaller caliber devices and compared to thrombolysis. So in 2022, that's when two big companies came out, and I won't hide the companies' names because we all know who they are, Penumbra and Inari. These two attempted to change the scene of things and give us that perfect device. So they came out with aspiration mechanical thrombectomy devices, that is to take the thrombus out. Now, the Penumbra came up with small to medium-sized devices up to 12 French until 2023 when they came up with the biggest size yet, the 16 French catheter, supported by computer-assisted vacuum thrombolysis system. At the outset, FlowTriever system by Inari started off big, 16 French to 24 French. I would say the 24 French works the best. Now, to illustrate this fight, this struggle in our minds as to which is the better product for us to use at 2 a.m. at night, this is the perfect case to illustrate. This is the only case I'm going to show. I've got an elderly lady, intermediate high-risk P, right heart strain on imaging modality, cardiac enzymes as expected elevated, tachycardic, but BP is still holding. But you know she's not going to hold for long. And of course, on the scan, you've got bilateral main pulmonary artery to bilateral proximal lobar clots. Right, we start off with the Penumbra 12 French device first because it has a well-established track record in the neurointerventional space, right? So we feel a little bit safer with that. So 12 French go in, as you can see, the catheter glides in smoothly, bilateral aspirations. So when quite a few passes on the right, quite a few passes on the left. But unfortunately, this was what we got. You know this doesn't translate to what we saw on the CT picture. And the reason for that is because we have a small bore catheter, 12 French, smallish. So there's a lumen clot mismatch. Now if you look at any normal scan of a small size Asian lady, so not just a big guy, right? If you measure the true diameter of the main pulmonary artery, you're getting something like 22 millimeters, 23 millimeters. If you go down to the lobar branches, you're probably going for 18, 16 millimeters in size. Now, how does a 12 French catheter fit in? It's a 4 millimeter inner diameter size, right? And that is in relation to the clot that's filling up and obstructing the vessel. Right, so there is a mismatch, and what you're really doing is digging around this clot, and therefore you're really trying to scrape off bits and pieces of clots and sucking them out along the way. Of course, you can do that, and if you spend enough time, this is after 2 hours, if you spend enough time, you surely get everything out in bits and pieces. But then the other problem comes, right? You have blood loss, which is inevitable at the end of 2 hours. You have 400 mils of unreturnable blood loss from the aspiration system. So what do? The patient's still unwell, right? Tachycardic, and we know we haven't taken out most of the clots. So we called in the FlowTriever system. To our surprise, this wasn't the first time we are using this, but we are getting a little bit more familiar with this. And you may be surprised, for those of you who are not used to the large bore catheters, how well it glides over the stiff support wire. So single pass on the right, single pass on the left. And then we got this. Corresponds very well to the CT images in terms of size, in terms of anatomy. So I think we should be done, right? But because I'm usually a little bit insecure, especially in the middle of the night, I don't want to be called back. I want a patient to be 100% safe from this procedure. So we have the privilege of having this, this hybrid CT room that we can do an on-table quick CT fluoroscopy. As you can see here, quick injection, one single slice, one single rotation generates a 4 centimeter thickness cut across the main pulmonary branch, enough for you to see all the important proximal branches, right? So now we've confirmed clearance of clot, both imaging and visually by visualizing the retrieved clot. So really now we've got good lumen clot matching. With a 24 French catheter, we have an inner diameter of 8 millimeters. Now, if you just look at the Inari slide, you can actually fit more than 2 of those 12 French catheters inside. And it is way bigger than the 16 French catheter. And just simple physiology, simple physics, you know that the aspiration flow rate is going to increase exponentially as you upsize the catheters. So now looking at our wish list, right? So is this doing it as fast as possible? Yes, the puncture to groin time took less than 1 hour, and this is a single operator procedure. There is immediate clinical improvement. Pulmonary arterial pressure dropped drastically to near normal, 40 millimeters mercury. Her dyspnea and chest pain resolved immediately, almost immediately. Her heart rate went down to near normal. And we know that tachycardia is quite an early indication of normotensive cardiogenic shock, right, before the BP drops. She went to the general ward the next day after 1 night of monitoring in the ICU. She was discharged on day 4 of admission. Right, can we take out the clots as much as possible? I think the picture speaks 1,000 words. We've taken them out and we've proved them that we've taken them out on CT. Now, are we doing this as safe as possible? This is when I acknowledge both Penumbra and Inari, because both of them are really churning out high quality data. So without going to the details, Inari has their FLASH registry with around 800 patients showing a very low morbidity complication rate. And the same thing through their Penumbra STORM-PE trial. They've got a slightly higher but still lowish complication rate. So we know that both systems are safe. And we can see that both catheters, despite their large size, they glide really smoothly across the curves into both main pulmonary arteries and into both lower lobar arteries, right? But Inari has one little cherry on the cake in that it's got this flow saver device which reduces blood loss by filtering the aspirated blood. And it's a very simple concept. So through this procedure, I've got less than 50 mils of blood loss as opposed to 400 mils using the other device. So really, we thought we give Penumbra another try, right? So October 2023 is when they introduced the biggest catheter yet, 16 French. So by then we're getting the same kind of outcomes, unreliable, coming out in bits and pieces, as opposed to Inari, very consistent outcome, bits and pieces, as opposed to Inari. Sometimes you get a little bit more chunkier clots, but still less impressive than Inari, right? So then, you know, between 2000, this is the evolution, at least in my center. Before 2022, primary treatment is going to be chemistry and a lot of praying during that time. The chemistry, the chemicals work. You pray that the patient doesn't have a complication, doesn't deteriorate and improve, and you plus minus have some catheter-based pharmacomechanical solutions. Then we move on to 2022 and 2023 when we have our finally the purpose-built devices, which are aspiration mechanical thrombectomy devices, and that was the time where there was a fight between the smaller ball catheters versus the larger ball catheters. And of course, right now, 2024 onwards, we have found success with the large ball mechanical thrombectomy device. We have a mature PE service. We have a dedicated specialist consultant-led referral pathway from the A&E and from the intensivist. We've done 49 cases to date, 1 pigtail, 2 ECOS, 7 Penumbra, and the rest, 39 of them, are Inari. So I don't need to tell you which is my preferred device. So before I go, I just want to help out my fellow Singaporeans. We are having this joint AOCR SGCR WIRES conference in Singapore, August of Singapore, right? Where we're gonna have some fun in the day, learning stuff. We're gonna have some more fun at night where I show you around the night scenes of Singapore, right? Over here, I've bagged the committee to give us a 10% discount for our Indian friends, ISVR friends. Right, so if you want, you can scan the QR code. So yeah, thank you so much, guys.
I'm glad I have a small crowd this weekend, and I'm actually looking forward to the music that tells me I have 2 minutes left. That's pretty good. By way of introductions, my name is Justin Klein. I'm representing a company called Guide AI Health, and I'm sure everybody's really up to speed on how popular AI is. And I mean, AI probably not as popular in the healthcare world as we'd like it to be, but it's really starting to come around. It's really starting to become dependable. And Guide AI has developed a model that identifies vascular disease. And we started, no, I thought that was me. I was like, that kicked something. Okay, perfect. We've developed an AI model that identifies peripheral vascular disease and vascular disease generally, but we've started with peripheral. And you're probably wondering why we started with peripheral vascular disease and why we started with vascular disease at all. Not that many people are doing it. It's really difficult. It takes, and for anybody that knows technology, artificial intelligence is built on training that model on a specific amount of data around studies that have been validated and annotated to really make sure that it's giving an accurate depiction of an accurate reading of an image. So we started with peripheral vascular disease because, as you know, if there's doctors in here, if you're a radiologist, it goes, peripheral vascular, PAD, goes undiagnosed the most. Almost 85% of the time, it goes undiagnosed until it hits that latter stage. And we thought it would be a great place to start and build our model. So, oh, wow, I should have just used the controller. Okay. So our imaging technology is something that can be integrated into PACS systems, into the workflow of radiologists, and a lot of artificial intelligence that's in the system or is in the sector right now is not actually providing a large amount of data. It's really giving operational data. It's really capturing things around how many scans were completed, how many patients did we have with a specific kind of stenosis or occlusion or plaque morphology. But our platform is combining both the vascular readings that we have through our AMI model and combining it with clinical context. And I think this is important for the imaging sector because the clinical context around imaging output and results of scans has not been something that's been included in large data sets. And so we're currently working with a company called VRAD. They're the largest data repository for imaging in the United States. They're partners with us there. They do the education and implementation of artificial intelligence and high-level imaging technology in around 4,500 hospitals in the United States. And we've kind of, and we have an exclusivity agreement with them to use their data to train our model. So currently, we're doing peripheral vascular disease, but we've already mapped out the carotid head and neck, as well as the abdomen and pelvis. And I think some of the feedback that, and we were at the Involution booth during this conference, and some of the feedback that I got was that the doctors are ready for it all right now. They want the peripheral, they want the abdomen and pelvis, they want the head and neck. But the one thing about the vasculature is that it's an extremely difficult area to map. And so we started with the peripheral vascular disease because we believe that we can give the most ROI to hospitals and actually create a patient data set that currently isn't really being looked at. And if we can identify disease early enough, we can set people on a pathway for the right equipment, the right procedures, the right surgeries. And we wanted to build something that wasn't just for radiologists. A lot of imaging has been kind of set in the radiology kind of sector, and we want to use this for cardiologists, vascular surgeons, interventional radiologists, because if artificial intelligence can help those doctors, even cardiologists in their clinics, to read files and to read imaging, we'll be able to ease the burden on radiologists, which currently right now is actually a big difficulty. You know, when I first got into this, I thought, you know, I looked at all the doctors and I looked at our tech team and I said, are radiologists going to actually accept this? You know, they think that we might be taking their job. Well, it actually turns out that radiologists are so overwhelmed, and specifically in India with some of the highest rates of vascular disease, that they can't meet the demand for the supply of patients that need this kind of service, need this kind of readings. And what that ends up doing, it ends up affecting quality, because they're trying to read as many scans as they possibly can to get through their patient demand. And that's actually causing inaccuracy. So we built a tool that we believe can assist that, can open up the bandwidth of a radiologist, can help them to do more scans and meet the demand of their patients, but at the same time, effectively be getting an extremely accurate reading, both from a specificity standpoint and an accuracy standpoint. So we have originated in the United States, and in the United States there is a heavy pipeline for regulation in this sector. You have to have certain FDA approvals, and that's all the way down to where these kind of products fit in the workflow. So in that, we are only releasing so much at a time, but we have a full vascular assist platform that will be identifying occlusion, plaque morphology, obviously stenosis, and measuring length of lesions as well. So we're hoping that as our model progresses, this will be something that fits into vascular surgeons' workflow as well, so that they can start preparing for surgeries in a whole new way. And that's kind of our goal as we start to drive this forward. So let's go back to the clinical context and biomarkers. So what we found is that these data sets are really giving positive and negative results. So we're using our platform to be somewhat of a data hub to provide clinical context, looking at biomarkers, looking at medical history, and combining all of those things to help interventional radiologists, vascular surgeons, and cardiologists look at the whole picture. And what we also found is that many clinical trials in this sector are lacking just that, a full patient data set that allows them to look at imaging, how it's affected, how many procedures that have happened, how many surgeries that have occurred, and exactly where clinical and medical history relates to those outputs of some of those imaging results. Let me go on to the next one there. So basically what I was ending on that slide is there's not a lot of longitudinal data around medical history, the patient, what procedures, equipment, and surgeries have been recommended, and we're hoping to help doctors to start building that data set. And we believe that it's going to initiate a whole new set of clinical trials that will allow us to look at a broader scope from that data set. So we're end-to-end, and basically while we started with PAD first, we're moving on to the carotid, head and neck, and the pelvis and abdomen. And again, where we believe that artificial intelligence in the imaging sector can really benefit clinics, doctors, and hospitals is that it's also a revenue enablement tool. And it helps them to look at a whole other set of patients that might not have been able to be recommended for procedures, surgeries, or even catch it early enough where we can send them down a whole nother path of health. And so if we're able to catch vascular disease at its roots, we can look to start eliminating, removing limbs, and that kind of thing. So this is really our goal, is to really not only identify disease earlier, but it's to identify disease in a manner and early enough where we can set that patient on a whole other trajectory. So let's look into our structured reporting. So right now, and I'm going to show you a video here in a second, but right now in our platform, we can identify basically the percentage of stenosis, occlusion, we're working into plaque morphology, and we can really give down to the percentage by 95% accuracy of what the vascular disease level looks like. And so that structured report is going to be absolutely imperative for cardiologists and vascular surgeons to make certain calls when it comes to what kind of procedures, how they're going to approach the surgery, and what the next step for the patient is. So, how does the artificial intelligence work in this zone? And that is, firstly, you have a model, and that model needs to be trained by data. And it really matters what kind of data that you're getting, who's annotating that data, and how we're ingesting it. But the regulation around the specificity and accuracy of this kind of technology is significant. So right now, for PAD, we're currently around 92% accurate. And that is still not enough for everyone. But again, when we look at the demand that's in this sector for radiologists and interventional and vascular surgeons, that kind of accuracy will help. And what we found is in the data that we were training our model on, almost 7 to 10% of lesions were missed. And we're talking hundreds of thousands of studies that we put that we train our model on, and mainly from the United States. But at the same time, I found that to be absolutely just amazing that there's been that much missed. And again, a lot of the factors isn't just the fact that there's a high demand of patients. It also comes down to what can actually be identified by the human eye entirely. So the more data that we train the model on, the more accurate it will get. And eventually, we think from 5 to 7 years from now, you won't have to go in for a physical biopsy. You'll be able to really break apart a lesion just from looking at the imaging results and really start to map out the vasculature in depth. And I think right now, when it comes to artificial intelligence, a lot of people are doing, I went to a conference in Chicago this past, about a month ago in Chicago, RSNA. It's one of the biggest imaging conferences there are. It was about 70,000 people. There were so many artificial intelligence solutions, but I only found one that was trying to attempt doing the vasculature, and they were very far behind us at that point in time. So it really is something that is difficult to do. You have to have the right kind of data. You have to have the right kind of tech team to annotate that data, and you have to have the clinical backing to do so as well. So when we look at just the flow of how this fits into, not the flow, how it actually fits into a doctor's workflow, that is actually really important. So we're doing customized integrations into PACS systems so that we don't really move the dial too much on radiologists' workflow. I think it's important that we don't touch doctors' workflow. They've been doing what they've been doing for 20, 30 years. But it still fits into that PACS workflow. And when we look at cardiologists and vascular surgeons, they haven't, while they've been looking at some of the imaging, prior to surgeries and before making a call, I mean, most cardiologists that we work with have not been using imaging in some of their treatment plans that they're recommending for their patients. So we're trying to make the platform easy enough where it's readable by any professional. I'm already down 2 minutes. So we do outputs on lesion localization, vessel segment mapping, stenosis occlusion and detection, severity of quantification, overlays of visualization, and confidence indicators for review and support. We're currently running our model through several clinical trials. We just cleared our first FDA 510 clearance, and that is coming on only our first one. And the FDA has given us, if anybody's familiar with it, breakthrough status as being one of the first people or one of the first companies in the world to have attempted it. So we have a lot of good backing. We have the team to make this happen. And really what we are looking at now is, where does AI sit in the workflow? How is the market going to absorb this, and how are the doctors really going to want to use it? And so we're working in that zone right now, and that's kind of my job, is to see where does this fit in the workflow and how do we apply this technology safely and without bias. So we have 3D viewers and all kind of things, so where you can kind of play with the image, go up and identify where lesions are located. It gives a structured report instantly. When you put the report in or a DICOM file in through our AI, it only takes around 5 seconds. And in our first pilot, or in our first 5 pilots in the United States in hospitals, we actually didn't put it in the workflow. We did a retroactive study. So basically having the hospital put in the last 3 years of imaging through our artificial intelligence model so that we could look at how much has been missed, and not really just to identify how much has been missed, but to say there's a lot of ROI for the patient and the doctor that's been missed. There's a lot of bandwidth that we can create within that workflow, and I think that's some of the most important things for us. So can we just put up the video, guys, quickly, if you don't mind? The video is just a bit of our demo platform. Can you guys put that up, the video? Or is it on here? Sorry. Is it on here? Yeah, sure. Perfect. So this is kind of the just a quick demo of our platform and our AI working right here. So basically, we just have a layout of studies. You'll be able to view studies, and again, this would probably be our most minor, like PACS integration. Our full vascular platform will be somewhat of a data hub. We have a 3D overlay, obviously, and we are looking at a number of things. Lumen, how mild it is, the percentage of stenosis, the level of stenosis, and the occlusion as well. This is very easy for any doctor to actually read, and the structured report itself is pretty comprehensive. So I'll just jump to that just quickly, but you can remove the bone. See if I can, there you go. You have the lesions there, and it's very simple to read. It's color coordinated to essentially allow the doctor to kind of look at the severity. And then when we get to the structured report, this can give you somewhat of the percentage in each of the vascular as to how much the stenosis is, how much peripheral has been identified as it pertains to that person. It gives literally right down to the mildest percentage, and we're at about 92% accurate on some of these readings. And again, I want to emphasize that artificial intelligence, while it's kind of a buzzword right now, when you look at imaging and what's actually visible to the naked eye, this is something that is breaking through the industry. And it's going to allow doctors to really open up their bandwidth, evolve their workflow, and really look at giving really new kinds of pathways and trajectory changes for their patients. It's going to change the way vascular surgeons, prepare for surgery, map out how they're going to approach each patient, and really revolutionize the imaging sector. Thank you.
Good afternoon, everyone. Thank you so much for being here. We are starting our session in 5 minutes more. People are trickling in. Maybe 5 minutes more will be. Good afternoon, ladies and gentlemen. A very warm welcome to this non-vascular interventional radiology session. We're focusing on interventional oncology, ablations, and pain palliation, one of the most exciting and rapidly evolving areas in IR. We are honored to have an exceptional panel of national and international experts who will share the practice-changing evidence, first in the country experiences, as well as future-looking perspectives. Thank you all for being here. I'm acknowledging the chairpersons here. We have with us Dr. Deep Yadav, Dr. Shams Iqbal, and Dr. Arul Arokia Sasin Babu, and Dr. Amrit. Some of the chairpersons couldn't be here, but we'll proceed with the session now. First talk is by Dr. Govindarajan Narayanan. To begin with, we're going to speak about percutaneous Y90, the first in ISVR. So please.
Good afternoon, everyone. Thank you for the kind invitation. Honored to be here, especially to be able to speak in the city that I grew up in Chennai. So even though I'm not part of the organizing committee, a warm welcome to all of you to my hometown. So my next talk, the talk now for the next 10 minutes is on percutaneous Y90. As part of my disclosures, I'm part of the scientific advisory board of the company that manufactures this device. So all of you are very familiar with using Y90. Most interventional radiologists today have switched, especially in the US and Europe, from TACE to Y90 as one of their preferred methods of treating HCC or colorectal liver mets. And so the idea was to see how you could marry Y90 to the needle rather than having to do this via the transarterial route. So with the transarterial route, you have to do your mapping angiogram, you have to do your dose calculations, and then bring the patient back and then treat one lobe at a time. And so what would it be if you could combine Y90 in a needle and deliver it directly to the tumor? And that's the concept for beta-glu. So the beta-glu intradose is a targeted localized injection of Y90. The Y90 is supplied in a sterile vial and contains a fixed dose and volume, and it's usually optimized for handling at the nuclear medicine center. And in the middle, you're seeing the syringe. That's a bi-chamber syringe that uses both glue and glutaraldehyde. Both of them needs to mix to create the polymer. And so the Y90 is loaded in this device, and it's delivered to the room before your delivery. And following radiation safety precautions, you will be attaching what's called a cochlea. And the needle, the percutaneous needle, is something which we use every day in IR to do our biopsies. And once they're connected, you can then deliver it. You access the lesion under CT or ultrasound guidance and then deliver the Y90. So as we talked about the preparation, you have about a fixed volume of 2.7, but the dose that you're adding, the Y90, can be calibrated, just like what you're doing for your liver treatments. Initially, we did the first couple of injections freehand and quickly realized that the weight of the device needed some support, especially if you're going to be dealing with the pancreas, and that's when this stand was created. It's gone through a few iterations, and now I think it's a very user-friendly model now where you don't have to touch your device and you can push it with very minimal pressure on the needle. And once you're done with it, you do your standard Y90 PET scan to assess the delivery. What are some of the areas of application? The company initially started treating patients in Eastern Europe in both liver and breast, and then quickly pivoted to stopping human cases and decided to go the route of doing it the right scientific way by bringing in bench and animal studies before moving to humans. So the two first in human clinical studies were done in Georgia. 7 patients were treated with the HCC, and at that time it was called BAT90, and 13 patients were with DCI stage 0, 1, and 2A were also treated. So this is one of the examples of the patients with HCC. This was delivered with ultrasound guidance and the PET scan at 24 hours, and MRI at 21 days shows the area where the tumor was treated. This was in JVIR as in the poster, and safety-related outcomes. They did not have no complications with local or systemic toxicity. There was no leakage of radioactivity from the injection site, and effectiveness. Patients without disease progression. Again, it's a very short follow-up of 21 days, so you cannot draw any major conclusions. And patients who were deemed responders were 100%. One patient was found to have a complete response and tumor reduction about 86%. So as I said, they decided to rethink their strategy, and rather than going into humans as a 510K, they wanted to do a proper indication and do the animal studies, and the name was changed from BAT90 to intradose, and the focus switched to pancreas. So somebody who's been involved with pancreatic cancer and local ablative treatments for 15 years, this was something which was very interesting and appealing, the whole concept. As we all know, locally advanced pancreatic cancer, or stage 3, has several limitations as far as the treatment options goes. Most of these patients are treated with either systemic chemotherapy or radiation, but there are limitations to these because the tumor is highly hypoxic, and that impacts the effectiveness of the radiation in this space. And the tumors are also poorly vascularized, and therefore that limits the effective delivery of the chemotherapy. And not to forget the stromal tissue of pancreatic cancer, which limits the entry of these drugs into the tumor, which has kept our median overall survival needle around 12 to 15 months. And local treatments have come into play. If look at around the world, the most common local treatment used is either radiation with SBRT. Proton and radiotherapeutic drugs, I would say, more experimental, but we all know the data on SBRT in pancreatic cancer could be debatable. But radiation has a new tool, which is MR-guided LINAC, and with the TTF fields showing some promise with ASCO. There are now studies combining MR-guided LINAC with TTF fields to look at their effectiveness in pancreatic cancer. And IRE as an ablative tool has been used around the world, both in surgical settings and in percutaneous option to treat pancreatic cancer. But as those of us who do IRE of the pancreas know, that it is not a simple procedure. It's pretty challenging. Your needle placements have to be accurate. There's a whole protocol involved in this, so I'm not going to go into that due to the lack of time. So that's why placing a single needle and delivering Y90 directly to the pancreatic cancer is pretty appealing. This is an image from one of the animal studies that we did in Boston, where you advance the needle under CT guidance, you get it to the pancreas. Of course, the pig anatomy is different, and once you're in the pancreas, you push the dose, and it polymerizes in 15 seconds in that area. So this was just a quick video before we go into the actual studies. I tried to trim this video and show you the exact space, but I was not able to. I'll try to pause it. And whoops. So this is after 24 hours. There you go. So this is where we delivered the dose, and you can see there are some GI structures in very close proximity to it, but none of them were damaged when we saw the patient in necropsy, the pigs in necropsy. So this is the same animal 7 days post-injection. So this is the graph of where the amount of dose of Y90 that was delivered, and we were able to get a mean dose of 222 gray. For comparison with MR-guided LINAC, where you're able to deliver much higher doses compared to SBRT, you get 50 gray to the pancreas, whereas with intradose, we were able to go even as high as 222 gray without damage to the surrounding structures. So quickly going through the three main preclinical studies that have been completed. The first is the first of its kind in pancreas, which is the OncoPig study, followed by a murine study in Berlin, and then a GLP safety study mostly done in Boston. So the OncoPig study, I'm not going to go into the details of the creation of it. This is a genetically modified pig where you're successfully able to create pancreatic cancer tumor in the pig. And so we used about 6 genetically modified pigs, and these were followed for 30 days. All of them were successfully injected with the intradose. One animal was sacrificed early, but it was not because of the intradose. Complications was more related to the creation of the pancreatic cancer in the animal. None of them had any leakage, and the histopathology revealed strong inflammation in the necrotic region without damage to the adjacent structures. This was accepted as an abstract, poster abstract at ASCO this year in 2025. And moving on to the next study is the Charité study in Berlin, and this was to study the effectiveness of intradose in a murine model with pancreatic PDAC cells in PanCa-01 cell lines. So these mice were all immunocompromised, and the pancreatic cancer cells were injected, and they were incubated for 2 weeks prior to the implantation, and these tumor cells were subcutaneously implanted on the dorsal surface of each mouse. I'm going to show you a picture so you can see how small the whole experimental animal is. There were 3 groups. The first group was the control group, which did not receive any treatment. The second one was just the glue. 5 mice were injected with just glue, and the third group was injected with the intradose. And there you can see the size of the mouse with the tumor that's grown on the surface. And the challenge in this particular study was to hold the mice and inject the dose appropriately, because given the size of the animal and the delivery of the dose. The study was completed. All animals received the dose. There was no significant adverse events, and the appetite and activity remained normal. So when you look at the results, the tumor growth, there was continuous tumor progression observed in the group that did not receive the intradose. The group that only got the glue, the tumor growth slowed slightly but then progressed. And the one which got the intradose, the tumor was significantly reduced up to day 21, and then there was an increase in size observed. I'm going to show you why. So if you look at the first picture, the area where the intradose did not penetrate is here. That's the area of the tumor, and you can see the part where the intradose did get in. And the second picture, you can see where the Y90 glue is in the part of the tumor that could not get the Y90. Mainly the limitation was the size of the animal and the ability to inject, and here's the PET scan of the same thing. So the conclusion of the study was you were able to inject intradose next to to demonstrate a therapeutic effect and tumor growth stabilization. Again, short follow-up for 21 days. All safety profile metrics were positive. And there was a statistically significant difference in the FDG PET uptake in the area where the intradose was implanted versus the rest of the tumor. And finally, to the last one, which is the safety GLP study. In this, there were two groups of 6 Yorkshire pigs that were chosen, and the first group got a controlled delayed or decayed intradose, and then the next group received both low dose of Y90 and a high dose of Y90, and all of these pigs were followed up to 90 days. And these were all done under CT guidance. This was done by 3 of us. They wanted a variation in the physicians who would inject it. So 3 of us did these injections on 3 separate occasions. And then the PET scans were obtained immediately after the injection and also on day 7. In none of the animals there was any leakage observed, so it was very impressive to note that the injection polymerized very quickly, and there was no collateral injury to the adjacent structures, and all the animals did well after the injection. The delivery efficacy of 80% was achieved in 3 of the animals, and in 3 of the animals we could not get 80%, although they were very close. The lowest was 76%, and the dosimetry was performed with the MIM software. And this is an image of a high-activity injected pig where we were able to deliver up to 233 gray and without damage to the adjacent structure. So the study concluded that all animals that survived to 30-day point gained weight, and they maintained adequate body condition. There was no evidence of failure with the device, and the PET scans showed that the radioactive signals at the treatment site without any off-target signal. So what's the next step? Human trials, and they've done a remarkable work in the last 18 months. They managed to get all the animal studies done and then create the protocols and then submit it to 3 different countries in the UK, and Belgium and Italy. And as of a couple of weeks ago, all 3 studies have been approved, and human enrollment is going to start. Time's up, so I'm going to skip this. This is a multi-center, open-label, prospective phase 1 trial where we're going to be using 10 patients, and they're going to be injected with intradose directly to the pancreatic cancer. These are stage 3 cancer patients, and we're going to evaluate safety, efficacy, quality of life, and multiple other factors. Hopefully, get to the phase 2 in the United States after that. So this is the schema of the study, and these patients will, once they're diagnosed with locally advanced pancreatic cancer, they'll be followed with their induction chemo to see if they progress. If they progress, of course, they won't be part of the study, or if they are surgical candidates, they will not be. If they are not, then we would bring them back for their systemic chemo and then interspace the Y90 injection at day 22. So these are the 3 sites. So to summarize, this is an exciting area of expansion of the application of Y90, especially bringing it to the percutaneous space where you can complete the treatment with a single injection. And hopefully after pancreas, we will see more data on the pancreatic studies soon and expand this to phase 2 trials. Thank you very much, and that's the Beta Glue team, and thank you.
Great presentations. Amazing. Too many questions going, and I'm sure everybody's mind is racing. I'll just ask one question, because we know, like, you're working primarily on the pancreatic cancer, and we know it's an immunoprotective environment because of the sclerosis and the way it goes, neurovascular extension and all those like issues which we face, and that's why none of the modalities have been successful in the pancreatic field. Glad you took this challenge heads up. And considering the fact that when we treat from angio, we know the way the vessels come, they go from outside in, and that's what we are all used to treating the Y90. And whenever we do ablation, we treat from inside out. And here you're using glue loaded with the Y90. Again, I don't know the PKs and kinetics and everything. So I was wondering, how do you envision, because just in the form of ablation or something in the same vein, that you treat, the glue goes enough in the tumor and slightly make it in an R0 resection kind of thing. How do you envision that?
So the initial goal is to inject in the middle and then it permeates out. So the goal is to have, not to completely ablate the tumor, but to see if these patients can be downstage to get them to surgery. But then there's also plans to see if this could be just a local ablative treatment, depending on what we're going to see in the first 30 patients that are going to be treated in these 3 different centers. So just like you, I'm also waiting to see how it turns out. So far, in the animal world, it's done really well. It's exceeded our expectations. And to answer your question about immune markers, I didn't have time. There are tons of slides where we've looked at all the immune markers have been assessed in these animals, and there was an uptick that was noted after these injections. So that's also an exciting area, but and I didn't have enough time to cover all that.
No,
so
I know this can go for days.
Yeah.
I live about a mile from CVSED.
Oh, okay.
So that's
okay.
very interesting when I saw that.
Yeah.
So anyway, and you saw that in the Charité study, because the area where you could treat was gone, the area where you could not treat had the rigorous.
Yes.
And that's what I'm concerned, like, again,
yes.
everything has challenges, but that's the challenge.
No, there's a lot to learn. Of course, even though we get to 300 gray with this, Y90 radiation is different from SBRT. So what is this going to do? What kind of effects we're going to see in humans? Probably by next year, we'll have a lot more to talk about.
Really excited to look how it comes out.
Thank you.
Appreciate it. Thank you. And in the interest of time, I think we should continue and we can have more questions later on. Sorry, I took
Sure, no
time. Thank you. Thanks, Dr. Govindarajan.
The experts are also going to be available until the panel, so we probably save some questions then. Next, we move to another modality, which is gaining global attention. I'd like to invite Dr. Franco Orsi to speak on electrochemistry. Thank you.
Thank you. Thank you. Thank you, Chairman. Thank you, dear colleagues. I will talk about the I will talk about electrochemotherapy for liver tumors. It is a different mechanism of actions of the previous technology. It is something already available for human beings, and there's a lot of experience in many centers. But however, we do not have any data coming from trials. We are running a trial that is sponsored by Cardiovascular European Society of Interventional Radiology. But I will share with you the reason why ECT may have a room for these liver diseases. We know that, percutaneous thermoablation is a well-established way to treat liver cancer, both primary and secondary tumors. But there's a lot of situations where we are really afraid to damage the sensitive structures close to the tumor when the tumor is very close to, for instance, bile ducts, such as in this patient here. Or in this patient who was treated with Y90 and he relapsed with a peripheral viable tumor very close to the tinea white spot that is the bile duct for the posterior segments of the liver. It is not a thermal ablation device, and according to the data that's been done in animals, we know that the temperature surrounding the electrode did not exceed 44 Celsius degrees, so it means it's not any thermal damages to the structures. It is a little bit different than what happened with IRE, where the temperature usually rises up over 50 Celsius degree. The mechanism of actions is completely different. Of course, it will combine electric pulses with the chemotherapy, and the agent is bleomycin. And the electric pulses will allow for a transient permeability. It is increased, so it is a reversible electroporation. So the membranes will open up the pores. The chemotherapy will go inside the tumor. Then the membranes will close the pores, and the chemotherapy will be trapped within the tumor, within the cell, within the tumor cells. And of course, it preserves vital structures because it's not thermal. So this is the workflow. So we need just to inject intravenously the bleomycin according to the dosage in the patient square meters. So after 80 minutes, the bleomycin is circulating in the systemic circulation, so it will be outside any cells because the molecules is so big that it's not penetrating the tumor cells. Then the electrical pulse will open up the pores, so the drug that is surrounding the cells will go inside. And then after 40 minutes, the membrane will close again, and the tumor will be treated with the chemo. So this technology has been very well known by dermatologists, by sarcoma surgeons, because it's been used for treating superficial and dermal tumors. And since a few years ago, the companies introduced the needles that may be used to treat deeper located tumors in a custom geometry electrodes. So it means that we can combine a different position of the electrodes with define a perfect geometry surrounding the tumor, as I'm going to show you briefly. So the ideal lesions for being treated with this technology, of course, will be those lesions are resectable, not ablatable. This is important because we have a standard practice now that is a standard care that is thermal ablation for centrally located tumors. But however, very often it happens that we may face this kind of situation where tumors cannot be approached for thermal ablation. So tumor close to sensitive structures may be those tumors we don't want to treat with a thermal technology, with a thermal approach. So main bile ducts close to the structures, major vessels, surgical bed relapses very close or fixed by the bowel loops or abutting the porta hepatis. Almost every kind of tumor may be treated because bleomycin is not just dedicated to the specific biological setup of tumors, so it works both for primary and secondary tumor. Intrahepatic cholangiocarcinoma may be another possible target, and other metastatic disease. The optimal size will be over the size that could be treated usually with a thermal ablation. We also have experience in treating patients with progressive disease in one lesion. Meanwhile, the patient had other lesions that was responding, such these young ladies who was receiving chemotherapy for metastatic breast cancer. A huge lesion was dilating the bile ducts, so she was no more able to receive chemotherapy, systemic chemotherapy. So we treated the patient just for the central lesion, so she was able to receive the chemotherapy afterwards. The ideal patient for liver will be good performance status, of course, liver dominant disease, excessive standard therapies, and reasonable life expectancies. These are also some of the inclusion criteria for the RESPECT, that is a trial running by CIRCE. This is just an example. This is a patient who received other thermal ablation for other lesions, peripherally located. As you can see, after 4 years, he developed a new lesion in segment 3. It is a 90 millimeter hepatocellular carcinoma close to the hilum structures. So the perihilar location close to the left portal vein branch made the patient not suitable for ablation. This is due to the critical location, and it was included in the RESPECT trial. So we place 5 different electrodes, and we use 2,000 IU of bleomycin. Now you can see, the planning part of the treatment is the most important one because we need to play in offline just to be sure the geometry of the needle placement will be perfect. So you can see this is an offline planning. The lesion is here. This is arterial phase. This is a late arterial phase. This is a portal one. So we usually work with the axial plane just to define where to put the lesion, the needles. In the axial, then we switch on the coronal one because we will go in the axial plane using CT guidance. So as you can see here, we place the 5 landmark where to land it with the tip of the needles. They are 21 gauge needles, so you can cross any structures you may meet during the needle position. Sometimes it happens we need to deal in this very, very risk position, but however is again is a 21 needle gauge. Then we put the landmark here, and then we will see on the axial plane where is the entry point at the skin level. So you can do it more easily if you have, robotics or some specific navigation system. However, the planning stage is of paramount importance in this treatment. Then I will go a little bit. Okay. After all the landmarks has been placed on the skin surface, we can start placing the, placing the needle. The patient has to be in general anesthesia. This is fluoroscopy. Then we will try to put the needle in the perfect position by respecting the planning. After that, we need to be sure that all the needle is in the right position, not only in the deeper part, but even in the geometry. They need to be parallel, as you can see here. More or less, all the needle has been placed around the tumor. So we don't need to touch the tumor itself because we need just to create a volume, electrical volume. Then we can play with the images in order to be sure that everything is okay. Before to place the wires at the needle, then the electrical pulse and volume and power will be set on the machine in order to be sure it is almost the same that it happens with the IRE. And you will see that during the pulse, electrical pulse, the muscle will contract. That's the reason why the patient need to be in general anesthesia with muscle relaxant drugs. The results may be seen immediately after with the CT. You will see shortly the CT that's been done immediately before the treatment because you will see that thanks to the so-called vascular lock, all the vascularization, all the arterial supply to the tumor will be completely locked. And this just for the final result is the song. So the results is very amazing immediately, but it's even amazing if you follow up the patient currently. As you can see, 24 hours later, 1 month later, 1 year later, actually the patient has 1 year and a half follow-up and is still disease-free. We also perform MRI in order to be sure that the lesion is DWI negative. So, of course, there are some tips has to be taken in consideration. So, electrodes must be parallel. It is important to respect the maximum distance between needles, otherwise the electrical field will be unhomogeneous. And the electrodes has to be placed perfectly around the tumor. We don't need just to place the needle inside the tumor unless the tumor is too big. And this is the pivotal needle that has to be placed in the middle just for avoiding the distance from each needle will exceed the 3 centimeters. And planning guiding, again, is of paramount importance because it's important just to place. I mean, all the procedures is based on the needle placement because the treatment itself lasts no more than 5 seconds, 10 seconds. That's very, very, very short. So navigation technology is very welcome. As you can see, there's no issue crossing big vessels in a portal beam because it is 21 gauge. It's important that the tip will be not through the bile duct because of course there will be some damage. You have to consider to spend time and to be very, very carefully respecting the time. So you have to start the pulse delivery not before the 8 minutes after the bleomycin administration, in order to be sure that the distribution of bleomycin in the systemic circulation is good enough for being effective. And of course, post-procedure monitoring is a little bit different than what happened with the other procedures because sometimes it happens mainly, this is mainly true with metastatic disease, you cannot recognize immediately the results, but you may wait a little bit longer because it's not a thermal ablation, so you may wait for the activities of the drug that you injected. So thank you for your attention.
Anyone has a question?
A lot of them.
You want to take a mic?
Why do we need a modality when we already have irreversible electroporation? I mean, we are completely destroying the tumor in irreversible electroporation with a similar mechanism. Plus, we are adding a drug like bleomycin, which has potential lung toxicity.
Okay, bleomycin usually doesn't give any kind of toxicity at all. I mean, if you wait a little bit longer, I mean, bleomycin will be completely dismissed by urine without any kind of toxicity. The first question is a good question. However, we still are missing data of IUD in the liver. So the reason why I'm presenting this data because it's coming from a trial. It is the first trial on ACT. I do not have any data still because we are still enrolling until the end of January this year. And in the next few months, probably we will come up with the data. However, the mechanism is completely different because, I mean, we know that bleomycin is really effective, but it cannot be used because usually it cannot go inside the tumor cells. So this is the way to allow the bleomycin to be effective into the tumor.
So, extension of the same question, Franco. One question, do you think that, again, same like previous session, the extension of the tumor, which is where the metastasis will lead to, all the ctDNA and all the cells in the blood, they come from the periphery of the tumor. So, because you're covering a little wider field compared to like all the ablations we do and other things which you do you think we are covering more areas which is a little beneficial? Number one. Number two is like, it's a little bit of quite a few extra steps. Do you think it will ever see the mainstream?
Okay, the first question, I can tell you for sure, not only the tumor cells will be affected by bleomycin. So if you put the needle outside the tumor, you will also include a safety margin. And this is what happens usually when we do ECT in a metastatic disease. So the question you gave before today is really smart because, of course, one of the reasons why pancreatic tumor cannot be resected is because the boundary of the tumor is affected vessels. So you can treat the center of the tumor, but you may still have some infiltrations on the boundaries. That's the reason why we don't need just to treat the tumor itself. We need to treat the volume where the tumor is embedded. So we need to respect the geometry, and usually we want just to spare numbers of needles because they are expensive. But in the meantime, we need to increase the numbers because increasing the number means increasing the volume and be safer in controlling of the tumor. Regarding the phase 3 yes, probably will be the second step. But in my institutions, we are only enrolling those patients who cannot be treated with any other options. That's my indication. So it is a niche. But in high volume centers, this niche means 20 to 30 patients every year that usually have no other options, only palliation.
No, so I belong to, luckily, to a high volume center. We do like about 5 to 6 ablations a day. So we do face these things. So far we have been using IRE as our troubleshooting device because just for the fact that there's so many steps, general anesthesia, muscle relaxation, everything. So you're facing the same thing, and I think it's a little better because in the IRE, we go from tumor inside out. And here you're taking the volume. So I see well from that standpoint, and that's why I ask you, like, we don't do it yet, so we don't have experience, like, can it come to the mainstream, which right now it's like a long step, I guess.
I mean, I want to be clear. There's no competition in terms of ablation. So if I have a central located tumor in the liver, of course, I will go with the microwave. We do, that's for sure. But think about how many patients you see every day, or every month, without any options.
Yeah, that's why we have been troubleshooting those with like PET ablation, which luckily we have the machine. Not everyone can have that. So this is possibility for like extension of those things. Thank you. Thanks for your talk. Appreciate it.
Thank you, Dr. Orsi. Next, continuing with the theme of novel approaches, we have Professor Philip Pereira here to talk on synergies between ablation and immunotherapy.
Thank you. So thank you very much. Thank you very much to organizing committee to put this very, very interesting session on experimental, clinical, and preclinical studies. And my topic I will share with you is microwave immunotherapy. And take home, you know that there is different approaches, and probably the approach with the highest number or highest evidence is combining microwave local with systemic immunotherapy. It's not my purpose today, of course. I will try to make it more interesting than the combining systemic and local treatment. It's the use of a new product called IP001. And you will see that we are already in probably the last phase of the study, we're scheduled to have a randomized clinical trial starting in 2026. Evidence, is one of my hobby to produce clinical evidence. Should be the hobby of everybody in this room to propose clinical evidence. And I will introduce this new molecule, which is proteoglycan, glycan polymer, which is specific activity is to induce and to improve the stimulation of the immune system by combining it with microwave ablation. Just take on, there is two different approaches, advantage by using IP001. One is physiochemical. You will see, I'll show you only one slide, that this product is capable to memorize the antigen production of each tumor. Which is more the direct effect is a stimulation of the both arms of immune activation is the so-called innate arm and the adaptive arm. By different pathway, I will summarize you, mostly by increasing release of T lymphocytes, using T helper, reducing natural killer, etc. Before we was discussing about combining local ablation with IP001, there was, of course, a high number of in vitro, in vivo, and preclinical study. And just show you one slide showing the effect of IP001 alone on tumor tissue. And of course, for a talk, it is a really significant slide showing you from the left without IP01, and the reaction with a dramatic an increase of T lymphocyte reaction with mostly CD4, CD8, you will see later. But you see after only local injection of this proteoglycan or glycan, the immune reaction immediately after and during the next week after the one injection. If you want a little bit to summarize, you see on this table that there is some direct effect of IP01. Extending the release of antigen means secondary extending the immune stimulation, but also on the other path, on the increasing the inflammatory reaction, and the inflammatory reaction have mostly positive effect. Not only positive effect of on the destruction of tumor, but mostly positive effect. And altogether, these are the direct effect on this slide. As you can understand, we're not going into details now. But in summarize, you have two effects by using IP01 alone. It's a direct effect, the innate effect, and the adaptive activation. Then we start with a combination of ablation. At that time, it was radiofrequency and some laser ablation. Showing you on this slide is a very similar approach with an increase of T-cell and T-cell mobilization after combined therapy with ablation IP01. And on the left part of this slide, or the right part for you on this slide, is the increased release and the increased immunoactivation lead to more circulated anti-tumor cells in the blood, and a reduction here of the number of distant metastases by only treating the primary tumor. Also, the third point, what I said to you before, is the activation of a memory effect, so that in that case, mice were capable to, the immune system of the mice was capable to memorize the immune effect and the reaction, memorize the antigen population. And this is what this experience shows, that combining ablation IPZZ1 has an effect also not only on distant metastases, but also several weeks up to several months later. From that point, moving to first human study, and of course, phase 1 study to look at safety and toxicity are very important, as we showed before in your talk. What are the effects? Very low. I have a strong effect in one of my patients, by the way, with fever for 2 days, some cutaneous reaction, but that was everything. No pain, no vomiting, etc. So you have fever, you have some group have some pain, locally pain and swelling. But moving very fast to phase 2 study, and as you see that is interesting is we have very immunogenic tumor like melanoma or non-small cell lung cancer, but also including colorectal metastasis, HCC, and sarcoma is also a very immunogenic tumor. So in this study, we approach ablation and injection on IP01 in all these different tumors, non-small cell cancer, sarcoma, and colorectal liver metastasis. And what we could observe is, as I said before, in the preclinical study, an effect on the distant metastasis, a direct effect of the innate and adaptive immunostimulation, and this abscopal effect. This is what you can see here, the effect in distant tumor in a patient with non-small cell lung cancer, another person with colorectal cancer. It was not a surprise, but it was a very promising result, the effect of the combination of ablation plus IP01 in patients with colorectal liver metastasis. And you see here in this summary that the effect was higher for melanoma compared with colorectal, but 1/3 of patients had a reaction on distant metastasis also in colorectal patients. The abscopal effect with this combination were observed directly in intrahepatic tumor, but not the tumor we have treated, but in lung metastasis, but also in lymph nodes. We observe this abscopal effect and in some soft tissue metastasis. This is some example here of a patient with a tumor we did not treat and a positive effect 9 months after treatment of another tumor with a PET-CT, a similar example here with disappearance from distant metastasis. Maybe to summarize first is first ablation, increase of local antigen, increase of the release of antigen and anticorpor antibody in the circulation and effect in the distant metastasis. All these promising results lead us to start with a randomized clinical trial with a phase 2A and 2A and B tumor, which will be conducted by our contract research organization, Next Research, called the Injectable 3. Sponsor is Immunophotonics. CRO is Next Research together with the Worldwide Clinical Trial Society. And expert group network is provided by CERSE. It is a way to do it. It's not really difficult on a technical point of view. You insert an introducer. Through the introducer, you insert your microwave antenna to treat the tumor. And through the same introducer, you inject IP001 at the periphery of the tumor, not in the center. Because in the center, you have only necrosis. If you have necrosis, you don't have immune reaction. So you go at the periphery. It is a little bit demanding, but not for us, interventional radiologists. We are used to use 3D imaging, so we think also 3D. So we have to inject the IP001 at the periphery. It will be a phase 2 to 3 study. And we take a very challenging patient's cohort, is patient with colorectal liver metastasis. This study will be randomized, controlled, and patient blinded in a specific form I will show you. We will look at progression-free survival, and of course, when we are discussing about abscopal effect, we will look at intrahepatic and extrahepatic progression-free survival. And we'll have also a blinded independent central review that is, in my opinion, very important to have, of course, an opinion from the local investigator, but also to have a blinded review of the result. Secondary endpoint, very similar also, extra and intrahepatic, and overall survival in this patient. We'll also look at some pharmacokinetic study and quality of life of this patient. We will start with a 1-to-1-to-1 randomization because we will use 2 different concentration of IP001, 10 milligram versus 1 milligram, versus ablation alone. And whenever I say it will be patient blinded because you remember you have only one puncture with a central introducer. So the patient does not know if he had IP001 injection or not. We also make a lot of sub-analysis, but I believe it's important to look at the primary tumor biology because we have so many different histological type of colorectal metastasis. Also looking if we have patients with synchronous, early synchronous, late synchronous, or metachronic disease. And maybe you have, I'm sure you have that in your experience. Sometimes you have patients with one solitary large colorectal metastasis, and sometimes you have patients with several metastases. Also important to look at all other, at this parameter, of course, KRAS, BRAF, etc. Phase 2A study, we will evaluate very early, interim analysis very early, to be able to perform a prospective randomized comparison 1-to-1 with the best of the 2 experimental arms. We'll take the best result from one experimental arm and perform the 1-to-1 randomized study. Follow-up, I will not go into detail. We need a long follow-up for that, of course, because we included not only PFS, but overall survival. So we are talking from interventional immuno-oncology, which is IIO, a new approach. And I cannot give you any result now, but I invite you maybe next 2027 for the presentation of the first result in this study. Thank you very much.
Anybody has a question? I'll continue then. So, Philip, very exciting field. You know, like this is the era of immunity. Everything is immune-driven. We are one of the sites which will be doing once immunophotonics will get approval with FDA. So we have been using similar pattern with viruses. At MGH, we have been doing some trial, and this abscopal effect has been kind of a little elusive, and we understand that the immunology is very, very complex, and the cell differentiation and cell population which is coming into the tumor is, especially we work on HCC, so it's very different. So hopefully in the collateral we might catch the tail of it. What's your gestalt on that?
First of all, I would say that it's a very complex thematic, and I was happy not to have to go into details of the first slide I show, because it's a lot of immune reaction. I cannot give you an answer today, of course, but I believe what we, like in the study that was presented by our colleague from Miami, is in the science we have to go systematically as fast as possible, but for this kind of new treatment, also ECT, preclinical, clinical, phase 1, phase 2, and now as fast as possible the phase 3 study. It's an indirect possibility to answer your question. We need clinical evidence, and we don't need 5,000 patients for that, but we need a proper study. I'm very happy that this study is conducted by Next Research, a proper prospective study, control study, and you don't need, to make as short as possible. If you have 20 studies that are observational study coming from 1 or 2 centers, and if you have on the other side, in the oncological world, one randomized clinical trial, your power will be much higher. So that's the reason I cannot give you the answer today, but to be scientific in that point of view with new competitive treatment is, for us, interventional oncology, very important.
Very much, sir, for making this complex topic understandable, and also for reminding us that the clinical research as a hobby is as important as a clinical practice to move the science forward. One short change, we are going to change the order of the talks just so that everyone reaches and catches their flight on time. May I request Dr. Naveen Kalra to take the next session on his first non-thermal ablation, his Indian perspective. This will be soon followed by the panel on non-thermal ablations. Dr. Seminwa will be talking right after that. Thank you. Thank you for the adjustments.
Good afternoon to all, and we've been listening to some very intense talks. Now moving on to our experience of the first non-thermal ablative practice of India, my experience. And I think this is intended to be like a prelude to the panel discussion that's going to follow on this one. So I have nothing to disclose. So as we talk about the non-thermal ablative practice, I'm going to talk primarily about irreversible electroporation. So this was a setup we did in way back in 2014, 4th September. And you can see here intense discussion going on between the director of our institute, the chairman of the specialty, and chairman of hepatology. And this is the map that we got from AngioDynamics initially, and at that point of time, we were the only facility in the country doing irreversible electroporation. So subsequently, it's now been started at Tata Memorial, Mumbai, and at Medicity, Gurugram. These are images, pictures from the 2016, and really thankful to Dr. Narayanan for coming up there and traveling all the way from Miami. He helped us set up this facility and establish IRE in the country and at our institute. So he was the primary resource person for the workshop that we conducted in our institute way back in 2016. I think everybody's looking younger there. So, we've had an insight into this already. IRE is a non-thermal technique, but we deliver here ultra-short pulses of high voltage, creates irreversible pores in the cell membrane, apoptotic-induced cell death occurs, the connective tissue framework and vital structures are not damaged, and there is no heat sink effect. Procedure done under general anesthesia with muscle paralysis, 2 to 6 unipolar electrodes positioned under image guidance, preferably CT, and electrodes are placed parallel to one another. We avoid direct puncture of the vessel. There's a R-wave trigger device, otherwise arrhythmias occur. So 3000 volts, 90 pulses in 9 sets of 10 pulses each, and mathematical modeling is done by the machine. And we have to be careful that the electrodes do not come closer than 1 centimeter. They do not go farther than 2.2 centimeters. The generator is recharged if the current flow exceeds 48 amperes. So definitely for those in our side who are trying to set up this practice, there is a steep learning curve. And the reason being, as already alluded to by my former speaker as well, so it is the accuracy and precision with which you have to place multiple probes under image guidance. They cannot converge, they cannot diverge, and they cannot be closer than a particular centimeter. They cannot be farther than 2.2 centimeters. So the organs that we have electroporated so far at our institute have been liver, gallbladder, pancreas, kidney, and lymph nodes. As far as hepatic lesions, it's again, perivascular or peribiliary lesions, usually the central location or segment 1 lesions, subcapsular lesions close to the diaphragm or the digestive tract, because you want to prevent collateral damage and you do not want incomplete thermal ablation. So our initial data was a retrospective study over 3 years, 2014 to 2017, that we presented at SIR 2018 and subsequently published it. This was on 21 HCCs and 21 patients with cirrhosis, and the HCC diagnosis was based on the ASLD criteria. The choice of IRE was based on tumor location. We had primarily perivascular and peribiliary tumors. We had some subcapsular or exophytic tumors, and then most of the patients were in Child-Pugh A or in BCLC stage A. The range was 40 to 84 years. The tumor size range was 14 to 40 millimeter, and the median follow-up was 10 months. We had technical success achieved in all of these patients. The local tumor progression was in 5 patients. The median time for local tumor progression was 4 months, and the median local progression-free survival was 7 months. The 6 months progression-free survival was 71.4%. So this is some of those cases. A 72-year-old female with cirrhosis had this hypervascular lesion in the central location. Multiple probes inserted from the anterolateral approach. We bracketed the lesion and there was no significant arterial or venous injury and a good ablation, though we did have some capsular leak and had a small pericapsular collection. Another patient with ethanol-related cirrhosis, again a central lesion 1.5 cross 1 centimeter. Using the anterior approach, multiple probes were inserted for IRE here. We had this bracketing of the lesion here, and again good ablation and no vascular injury whatsoever. We've again looked at some of our data and presented it at CERSI last year, and this was on IRE for HCC in difficult locations, short and long-term outcomes. And there were 48 patients and 49 tumors, primary males, and the etiology was either NASH or HCV, and primarily they were the Child-Pugh A patients that we had in our cohort. Most patients presented at an early stage, and again the tumor size ranged between 10 to 46 millimeter, tumor volume being about 10 cc. So immediate post-procedure CT that showed that most of these tumors, in fact all of these were non-viable when they were analyzed, And at 6 months follow-up, 36 observations maintained their non-viable status, whereas 13 observations demonstrated viable lesions characterized by new or recurrent AFI or washout within or along the treated zone. And there was no statistically significant difference in the baseline tumor volume between tumors which were viable or tumors which were non-viable. The 1-year overall survival being 74.5%, 3-year being 36.8%, median overall survival being 24 months, and we worked well with when there was like high-risk regions without damaging the adjacent structures. The complications, we had liver enzyme elevation in about 30%, and then the others were right pleural effusion, ascites, and segmental IHBIRD. Biliary lesions, this is another area where we are working. That's a locally advanced gallbladder cancer, which is extensive hepatic invasion with involvement of the surrounding lymph nodes and surrounding anatomical structures. So this was a study trial flow which we presented in SERC, and this is also published. We are comparing chemotherapy combined with percutaneous electroporation and chemotherapy alone in the management of locally advanced gallbladder cancer. So this is a 60-year-old female with abdominal pain and jaundice. You can see the arrow points to a mass lesion in the neck region of the gallbladder. We inserted 3 probes by the anterolateral approach. The immediate post-IRE necrosis, follow-up at 3 months showing regression of this tumor, and 6 months follow-up showing more regression of these tumors. So 71-year-old female with abdominal pain, with gallstones and a mass lesion in the fundus of the gallbladder. Using the lateral approach, we've used the 4 probe plan here. We kind of bracketed the lesion, immediate post-IRE necrosis. These are some of our pancreatic cases. So again, we are working in the locally advanced pancreatic cancer primarily. We have no experience with margin accentuation or post-surgical patients with recurrence. So some of those cases, locally advanced pancreatic cancer with a mass in the head region, that's how it looks like on ultrasound. And here we use a combination of ultrasound and CT to place our probes. And that's the probes within the tumor. That's the mathematical model. That's the graphs that we get during the procedure. And that's immediate post-CT, post-procedure CT, we see necrosis. It's another patient with locally advanced pancreatic cancer. Here we have a lesion in the neck region and the proximal body. 5 probe configuration used here to get into the tumor, immediate post-procedure showing necrosis of the tumor. So another difficult to treat locations that we worked in. So this was a female with solitary functioning kidney and had this RCC which was very close to the pelvic calyceal system. And here we use the 4 probe configuration to bracket the tumor and do our ablation without causing any injury to the pelvic calyceal system. This was a female with cholangiocarcinoma close to the IVC and the hepatic veins. The surgeon wanted a plane to operate and resect this tumor, so we went ahead and did electroporation of this one, and the surgeon got a margin to resect this tumor. This is one of the cases, one of the difficult cases where there was lymph nodes surrounding in a post-transplant patient, surrounding the vascular structures, and there was PET avidity. So here we used a 6 probe configuration to ablate these lymph nodes, and you can see the positioning within the lymph nodes. And post-procedure, you see that the IVC is patent, and the portal vein also shows good flow. So to conclude, tumor ablative effect of IRE is promising, effective for small tumors up to 4 centimeters, useful for tumors close to the blood vessels and other vital structures. Definitely not saying that IRE is going to substitute other ablative techniques. It's useful where other techniques are difficult or ineffective. I'd like to acknowledge our entire IR team and anesthesia team have a big role to play with IRE, including all my residents and fellows and the technologists who work with us. Thank you very much.
Again, open floor for any questions, unless Otherwise, I will ask a question. Sorry, Naveen. Thanks, a great presentation.
Thank you.
Really glad that you're pulling this off in India. So, regarding your presentation to CERSI in 2025, last year, you had most of the cases were in segment 5, if I remember it correctly. And you showed that the 1-year survival was like 74%, if I'm not mistaken. If you take all comers in BCLC stage A, usually the survival is like 78% in 5 years. So I was just trying to get an insight like why were the survival like a little off compared to the standard, because you're using IRE. Segment 5, it's hard to envision anything vital structure there. So
these were also, to tell you frankly, when we got IRE in the first go, we were more enthusiastic, and we did patients where they were even abutting the structures like the gut or the stomach, where even the diaphragm, we were as soon as we would figure out an observation which was close to the diaphragm, we went ahead, took those patients for IRE. But now our practice has slightly changed, that it is more towards doing it where we cannot at all do the other modalities like microwave ablation. So, and slowly I would say that the IRE, as we'll discuss in the panel, should have a niche area. It should not be using it, as a replacement for other modalities. And probably because this was a retrospective study, so that's the limitation of that one. So, at present, I cannot tell you exactly why these were patients which did badly, but that's I'm going to look at it. And yes, and so this segment 5, the reason I've told you why they were more lesion than segment 5, these were kind of abutting the structures, surrounding structures, or like close to the bowel or close to the stomach. So, or maybe close to the gallbladder as well. Yes.
So when you publish, maybe we'll have more explanation.
Yeah.
Second question, or a technical question, is like you showed the renal case. The lesion was very close to the collecting system, and also I saw the colon was closed. So, do you use hydrodissection or do you use pyeloperfusion? Because we use
for this one we didn't use anything.
Yeah,
we got away without.
So we do those things, and then we just do microwave or cryo, whatever you want to use. So that again, like upfront, you have a lot of work, but then it becomes very easy as opposed to like you do the procedure much longer.
So I think what we need to generate with IRE is more data, and perhaps, if possible, do some randomization. I know doing a study in IRE is tough, but doing it as a randomization would be tougher.
Even hard.
But actually, that's the way forward if we want to actually have enough scientific evidence to use it in situations where we are using other ablative modalities.
Yeah, so I can give you the real world experience, because luckily I'm in a position where we have pretty much extension all the way from MR guided ablation all the way to IRE and everything else in between. We started doing IRE about like 7-8 years ago, like 10 years ago almost now. And slowly we came to the point that like we just use it as a troubleshooting device. And now, as I said, like we do about 5 to 8 ablations every day, because we have 2 to 3 CT scanners just for ablation. So, but we use IRE roughly 10 to 20 cases a year. It's a very minuscule niche situation where we use those. So,
yeah, so our volume is not as high as yours, obviously it can't be, but still we get to do about 10 cases of IRE in a year. So, thank you.
Thank you, Dr. Kalra. Next, I invite Dr. Seminwa here to speak on renal tumor ablations, the current evidence that's driving the clinical practice. Thank you.
Okay, good afternoon. Thank you for invitation to beautiful part of India. And then my talk is on evidence-based renal tumor ablation. These are my disclosure. First and foremost, I'd like to thank my team locally to continue to support me so that I can continue to innovate in this space. So what I'm going to talk about, why do we need evidence, and how do we get the evidence that we need in our clinical practice, and what are the current evidence in renal tumor ablation. Just to take us through a glimpse of them ablations, we translate to an NHS clinic, from a heat-based energy radiofrequency ablations, the more recently microablations, and then for ice-based energy, we have the cryoablations. But not all tumors are suitable for thermal ablation, as the previous speakers spoke about. Certainly in our practice in NHS, we begin to have reversible electroporation since 2013. mainly in pancreas, then in liver, and then we also problem solve using in renal tumors. ECT is one of the technologies translated in liver, but not quite in renal in common practice. But we have opportunity to translate histotripsy in both liver and renal in the UK. So I have opportunities. We'll take it back the story because this is Professor Peter Mueller. He is the pioneer. In fact, he is one of those that are leading the cutting edge in renal tumor ablation. I have opportunity to meet him. I spent some time in Massachusetts General Hospital in Harvard. So Professor Peter Mueller performed the first renal tumor ablation, radiofrequency ablation, in 1998, and he published a paper in 1999. And then it's been taken out globally, in fact, all the practice. And Mayo Clinic published this very important paper, we call it a golden paper, published in 2019 in European Urology. It's very difficult for us to get into European Urology paper. They have close to 1,800 patients, and you look at the 5 years local recurrence-free survival, the cryo and RV are very similar, 95.9%, is trending just inferior to partial nephrectomy, and they actually acknowledge in the paper there's a selection bias because the surgical cohort are better patients. It has taken 18 years before ablations, stem ablations being recommended in any guideline, and AUA taken the first step. You can see that they recommend less than 3 centimeter tumor, and in the European guidelines is less generous. This is only for comorbid and frail patients, and this say that it's weak evidence. So how do we get the better evidence? It's all based on these pyramids. So we know that cohort studies is level 3 and 4, and then RCT is above it. Until we get critical amount of evidence, we are not going to be able to perform systematic review and meta-analysis to get the translation into guidelines. And we need to be in the guidelines if we want to be changing a practice once and for all. We were very curious in Leeds, so I had 2 medical students, they are now my fellows. And then we look at all the published data in 2021 because we really need to know. And there are lots of evidence out there. They're close to, literally, we have close to 75,000 patients. And then the ablation patient tends to be older. We know that it actually better for renal preservations and also less complication. And then local recurrence-free survival is trending towards partial nephrectomy when we follow them up long term. But the editors, militant, we cannot recommend ablation. They say you need more evidence, so we want to publish the paper, we want to publish evidence, so we've gone along with it. EAU guidelines today, in 2022, and currently still say weak evidence. So unless we want to change our practice, we need to get better evidence. So Professor Maxine Tran, she's a urological surgeon. Okay, you can see that she was amongst us. This is Maxine Tran. And she actually did a randomized control trial between cryo versus partial nephrectomy, known as NEXT trial. This is a core embedded. It's quite clever because you have a core patient. Within it, you randomize them. For a long time, we just couldn't randomize patient because patient is accepted. So she managed to successfully conduct this trial during pandemic. It's important to note because for this trial, you want to see the age of patients young. We wanted to treat younger patients and match against surgery. She has shown that cryos have less complication, have shorter patients' hospital stay. And this trial actually is the proof feasibility that we can actually randomize patients, the patient accept them. And clinicians also accept that too. So it's very exciting. This year, it's going to be announced soon by her that we're going to do a multi-centers randomized controlled trial in the UK. Quickly, just look at current evidence for renal ILE because I think a lot of people are interested. It's interesting that core researchers in UK actually did some systematic review up until 2020. You can see that they managed to get 10 papers, and amongst the paper, they're single digits. Only Conversa et al. From US actually have 41 patients. So they conclude that ILE is safe, but we need more evidence to know where it sits within the algorithm. And we published ours soon afterwards, and then there's one from China and one from US. And today, in total, the less than 200 renal ILE we published in the world, so we need more evidence. And actually, it was, we decided that the only way to move forward is to have collaboration. So we collaborated with Raj and also Jose Abdal from Madrid. So we pool our data together. We just submitted CVIR. We hope to publish it, and then we can come back and present to all of you in the future years. So what are the current evidence of renal histotripsy? We were very lucky. We were actually able to lead the global first. It's a feasibility trial to assess the safety and efficacies in translating histotripsy in renal tumors. This is a trial design, so it's a feasibility trial. We enrolled 20 patients, but only 11 patients going to have treatment, majority are male. And the tumor size, the median was 2.37 centimeters, and then majority were low complexity. This is what it looks like from baseline to a month. And then technical success was 100% at 36 hours, and then at 1 month is 90%. We presented this at CIRSE last year, and majority of patients grade 1 complication with hematuria. We have one patient requiring some observation. Indeed, it was the first patient because a prolonged procedure is a steep learning curve for us, but patient get discharged the next day without any sequelae. And what we learned from it is position is very important. For most patients in lateral decubitus position, you need to monitor the respiration because we don't have jet air ventilation in our institutions yet. And so you want to ensure the tumor is completely encompassed in the treatment zone. So what are the take-home messages? Level 1 clinical evidence important if you want to get into guidelines. Whenever we can, try to design RCT to address the evidence. And then it's very exciting. We are going to be finally, after 28 years since it first done in renal tumor ablation with RFA by Professor Peter Miller, we are going to randomized bleeding cryo and partial nephrectomy. Renal IRE is definitely problem solving, and we need more evidence. And renal histotripsy is definitely still in the translational phase. We did a feasibility trial. There's a hopeful kidney completed last year, so I think the result will be emerging this year, and it's a pivotal trial. So that will be the one that we decided by FDA whether they get approval or not. So on that note, thank you for inviting me, and I have a brilliant team, as you can see that, without them, I won't be here. And I even get to visit the site yesterday, so that was a real picture. I took that, so thank you.
Any questions in the audience? Okay, I have a comment and a thought. So you showed Peter's picture. Peter, I trained under him, and in that picture you have Ron Ariano. I share the office with him right now, so I'm blessed to be working with those giants. Regarding the histotripsy, we started doing that since last year, like 1.5 years now. Kidneys, we have been doing so far well, but in the liver, we did 13 cases. In that, there were 3 major complications. And all of these were like, one was infarction, one was aneurysm, and one was bleed. So again, I know the Wisconsin people where it was all developed, they are gung-ho about it. I know the chief medical officer of histotripsy also, they're like all about it. But they're selling a lot to the surgeons who don't have a lot of experience with ablation. So and then the other one big thing which came out was published was hyperprogression. There were 2 cases so far reported of, we all think about the abscopal effect, but you also have to look at the other side, which is hyperprogression. And we have 2 cases which is good enough to shake us to the core. So for the histotripsy, I'm a little bit kind of unsure. I was just wondering, what's your thought on that? What's your take on that?
I think it's in a very early translation space at the moment. I think there's a major marketing way of selling histotripsy. But from our perspective, certainly we were recently funded by NIH's procureur system. So from our perspective, when in the UK, it is very well controlled. We cannot just go off do anything. And I think that there is an appetite by the NIH, which is similar to NIH, to actually evaluate the patient in a very controlled environment. So we will have very tight indication how we can do it. But I always say that It's a really interesting area because ever since the trial, I was telling people I referred 2 patients to US, actually in private clinic. 1 patient actually had 20 liver mets on breast, and she's gone around world telling the story, and she had 5 lesions treated, and she's now in remission. The rest disappeared. So we just don't understand enough at the moment. I think there are a lot of research need to be done. I certainly, for myself, I won't be venturing doing difficult lesion. I'll do easy one, and then see where it takes us. I don't really know is the answer.
Thank you for the insight, because that's where we also come from, because we have 2 histotripsy machines. One we bought outright, and the second one is part of the Hope trial, Hope for Kidney trial. And I know we have Franco and Philip in the room. The issue is like till last year, till like December, the histotripsy company had sold 200 machines in the US. Each comes at a 2.5 million pop. 75% were sold to surgeons. And that's where the concern is. Like, we say, like, you know, yes, we keep talking about data, but if the surgeons say, okay, fine, we are happy doing it in the OR, we are at risk of losing, like, you know, losing is not the right word in this sense, but patients being hurt, because our trial, like our study was stopped after the 13 cases. We had an interim analysis and we saw 3 cases. So we feel like we should stop and reevaluate all the people who do ablation. We sat together, we're trying to figure out how to go about it, because we did buy a $2.5 million machine and we have to use it.
Can I ask a question?
Sure.
So in US, I mean, in your institutions, I mean, when you see Ron, say hello. I saw him recently. And then, can I just check, are the surgeons doing it in Mass General Hospital, or is it you doing it?
It's IR doing with the surgeons.
Okay.
Because they did buy the machine, but they don't know how to use it, so we do it together. But you know, as we saw in the graft world, till John Kaufman was in our system till 2001, as we saw in other fields, like now we are seeing like vascular surgeons doing geniculate RDMO and all those things. So they will slowly learn and they'll move on. That's the concern. But they should use the right technology. That's where my point is. The patient should not be hurt because
I totally,
yeah.
I totally agree, because we in the UK just watch US. We thought we are quite stunned by the major adoptions by surgeons and more by the radiologists, intervention radiologists. Certainly in UK we don't have that kind of issue, because people who has to use it has to be trained. So certainly in the government sectors, public sectors, is going to be intervention radiologists that who lead the program activities. And the thing is, in UK, it's very interesting. We all get paid the same, so no one's fighting for work, really.
That's the good part of your system. For us, it's a little bit different beast. So anyway, not to waste much time. Thank you. Anyone else question? If not, thank you for your great talk. Thank you.
Thank you. Thank you so much to all our speakers and the excellent work and the contribution you've done in the field of interventional oncology. Now we transition into a panel. The panel is moderated by Dr. Sridhar Shaluvashetty. We would like to have our panelists on the chairs on my left, please, and the chairpersons in the first row. So I'd like to invite Dr. Franco Orsi, Dr. Felipe Pereira, Dr. Semenwa, Dr. Naveen Kalra, Dr. Suyash Kulkarni, Dr. Dinesh Jyotimani. Dr. Govindrajan Narayanan unfortunately had to leave. All right. Over to you.
Thank you. Very good afternoon to all. I feel privileged to invite you all people, because the panelists that sitting here, I think by this time you know that how big names are there in the interventional oncology. I think most of the trials that we are discussing, they are part of that as a PIs. So some of the things are not yet come in India, like histotripsy and ECT, but then they are working as a PIs, co-PIs, and they are doing this project. So I would probably feel privileged to take this discussion forward. Not this way. And unfortunately, so this is on the future of the non-thermal ablation, global and Indian perspective in building the program. So unfortunately, we are not having Dr. Govindrajan and Dr. Suyash here to give us an American perspective, but I think I'll welcome Dr. Shams, because I know that he's equally gone through all the modalities, and then he would be probably able to take some of the questions which I have targeted at Dr. Govindrajan. So the three modalities that I'm trying to cover is IRE, electrochemotherapy, and histotripsy. IRE and electrochemotherapy are similar. The same pulse generator, same electrodes, only difference is the field strength. In IRE, it goes up to 3000 volts. In electrochemotherapy, it goes up to 1000. And the pulses, in IRE, it is up to 80 to 100 or 180, whereas in electrochemotherapy, it is less than 20. Whereas histotripsy, again, it also has a pulse generator, but then it has a focus transducer, which does the focus ultrasound waves as well as the imaging. So if you look at the setup, all of them have a pulse generators, electrodes, and probably a transducer. So this one, mechanics-wise, I think most of them, as you know, it's all non-thermal ablation, so less injury to the extracellular matrix or adjacent critical structures. So in the panel discussion, I'm asking few questions. Since I have experts, I just want the real-world experience because the data literature, I think all of us can go back and read. Due to time limitations, I would ask them, I would give only 2 to 3 points to the specific questions. To start with, first one is IRE in the liver. So what are the indications? I think I don't have both of them. Probably I'll throw this question to Dr. Naveen Kalra. Sir, what do you feel in the present world, where exactly you feel IRE is the indication compared to the other thermal modalities?
I think where we have, if we're looking at the highest level of expertise handling the ablation techniques, I would say the only niche area where IRE fits in today is the central hilar location sitting right over the portal vein or the next to the biliary tree, in the central biliary tree. And size, criteria would be less than 4 centimeters.
Okay. So what about the GB? So earlier we used to do something which is close to the GB other than perivascular and peribiliary was the...
So again, for the gallbladder, I would say when we are looking at their neck lesions, something close to the neck, definitely IRE is the modality that should step in and it outscores over the other ones. When you're working for lesions which are in segment 5, which is just abutting the gallbladder, there you, if you have that level of expertise, you could do it even with a microwave if you do some kind of dissection there and work your way. So if you look at niche areas, there are only these are the niche areas. Not saying that you cannot work in those areas with IRE. You can definitely work in the other areas with IRE.
I think moving on to my next question, that is with the pancreatic cancer. I think my understanding is that still it is not a R0 ablation with a pancreatic cancer. So we are doing IRE in a pancreatic cancer as a palliative therapy. So I would like Dr. Shams to take this question. Is the IRE for a pancreatic cancer is mainly cytoreductive or a local tumoral control or biological modulation?
So I have some thoughts about the previous point.
Indications.
Also. Yeah. So regarding in the liver paradigm, which you had the previous slide, we have a morning conference every day from 7 to 8 before we start all our procedures. And luckily, I'm blessed with working with, we have Rahul Appat, Ron Ariano, two of the big leaders of ablation world. And like then myself does it, and there are a couple of, we are 21 IR, so we are 5 or 6 of us who do quite a bit of ablation. So we run through like this kind of an internal tumor board on a daily basis, and we figure out, so we push the envelope quite a bit. And as you know, in the real world, time is of essence. Doing an IRE takes a lot of time and resource. So we try to push everything towards microwave or cryo if we can do that. Microwave is our first choice because it's much shorter, faster, equally effective. Like we feel it's better in our hands. Then the cryo, it takes a little bit longer time, and IRE is like much longer setup and general anesthesia is needed. So regarding the gallbladder thing, we routinely do dissection of the bare area of the liver. So that way we can save ourselves like all the extra work. Getting back to the pancreatic cancer, we mostly do it for cases which are kind of a borderline in the pancreatic tumor board, they're surgical or not. And we know for a fact that the IRE, the current transfers over the endothelial and it does not hurt the vessel. And there's a tumor surrounding that, and you know, like depending on where you work, general world is 50% circumferential. In our system, it's almost 70-75% because surgeons are more aggressive and they have more experience. They can chisel it out. If they're like somewhere in between, they're struggling a little bit, they ask us to do IRE, like to do some treatment. And we know for a fact, like microwave is not as great, other things. IRE is the choice to go there, ablate it, and bring it to the level where the surgeons are comfortable to go and operate. So that's our niche and the point number one, like most commonly where we use IRE.
I assume it is primarily for a cytoreduction.
Yes, you can call it like downstaging. That's what we call it. Yeah.
So I have the same question
Philip.
from Dr. Philip.
Maybe a short comment to add on your comment. You are talking about local expertise. It's a very important point, of course, because as many other centers and myself, we perform ablation even in tumor close to bile duct. I mean, it's possible. So we should not forget IRA and ECT is very promising. It's promising for the liver, but the aspect of the local expertise and why it is important. Why do I do that? Is if you don't have ERA and you have a tumor which is not in an optimal location, you can treat this tumor with other modality. It's my message. Yeah.
So I have this question on pancreatic cancer, if you can take up, like, do you do pancreatic cancer IRE as a part of cytoreduction or a local control? Like, which would be one of them if you have to choose one indication?
I saw in your presentation that you are also talking about ECT.
Yeah. I'll come back with the ECT as well with the similar question.
Okay. Yeah, because my answer will be ECT and not IRA. But I will go very short to your three questions. Cytoreduction, biological modulation, local control. The last point, local control, will be very difficult to analyze, even if you perform MRI or CT. That will be difficult. You have a desmoplastic fibrotic tissue that also in a three-phase CT, sometimes it's very complicated to limit. So local control is not a parameter for a study, in my opinion. Yeah? Biological modulation means
kind of immune modulation.
Thinking about combined treatment, for example. And there is two new studies performed by oncologists, one published in, two new because 2025, published with a checkpoint inhibitor, with also very interesting result. And cytoreduction, personally, I don't care about cytoreduction if the patient have not a benefit in the clinical outcome. So a minimum if regarding quality of life of this patient, because drugs and checkpoint inhibitor have an influence of the quality of life. Maybe looking at that point and looking at combined treatments that will have the advantage also to receive this patient from the oncologist, because local advanced pancreatic cancer are not patients that are in the surgical department. These are patients that are oncological. So I stop my answer. We will talk much more about electrochemotherapy.
Just to...
Yeah, please.
I'm a hepatologist, I'm not a radiologist. Okay. So thank you. So in your first question, you asked for liver cancer very close to the vascular structures. You prefer IRE. Is there a data that is superior to the TACE? That's what you would have done otherwise if a lesion is in the central location. Is there a data comparing to the conventional TACE?
Conventional TACE versus ablation?
For those difficult lesions where we don't want to do a thermal ablation but then end up doing TACE.
For which tumor?
The liver tumors. He's asking about the liver tumors.
Let's rephrase the question.
But which kind of liver tumor? HCC.
So you say like HCC, BCLC-A, and centrally located. Yeah.
But now you are recommending this treatment. Is
So
that superior to the TACE?
ablation is always superior because there's a completely fundamental difference of ablation and TACE. When we do ablation, we are going towards cure. We are looking at cure. When we are doing arterial-based therapy, unless you're doing RADSEG, we are thinking in the palliative paradigm. It's like right from the get-go. If somebody is in that situation where you have a lesion which is BCLC-A, but technically it's challenging, we do send it for SBRT. We have a very strong system there where like they're very accomplished people also. So basically it's the patient who gets the best service rather than me. But again, the advantage for us, like so Peter Muller, who started ablation, like was my teacher, and I'm from the SAR program. So we have a huge amount of experience, just like Philip has. So a lot of things which looks unablatable for others becomes ablatable in great hands. So long story short, if there's a lesion which you can feel that you can ablate, just ablate. There is no like alternate in arterial phase right now as we speak, but RADSEC can reach there. That's a possibility. Ablation is the best option. And to the point that if it's colorectal cancer, the recent study, the Collision trial, which showed that the outcomes, and you know, in the oncology world, OS is the king, overall survival. The overall survival of patients with below 4 centimeter who have colorectal mets, the ablation is as good as surgery with much less side effect, to the point that the study was stopped in the interim analysis phase because the DCMB felt that we are hurting patients too much by going the surgical route. So they stopped, and now surgeons, they refer this study and they send it to us. So HCC is similar, but HCC is a little better because it's a more pseudocapsule based tumor rather than colorectal mets or cholangiocarcinoma, where they're all insinuation if you look at the microscopic aspect. Again, I'm going rambling too far, but in long story short, if you can ablate, you feel like you can do it, that's the answer, always.
And the other challenge with doing a TACE for centrally located lesions is getting the entire vascularity, which I think all IRs can vouch for. Usually they will have very many small vessels feeding them. It's not usually a single vessel. So it's very difficult technically to do TACE for a centrally located hilar lesion as well.
I have just one fundamental question which in this slide, like you mentioned option being local control. Again, as I said, the king in oncology is overall survival. In the pancreatic cancer paradigm, local control does not do anything. Patients die because of metastases and other invasion. The local control, unlike as we are used to neuroendocrine tumor, so if you control the liver tumor, you can increase the overall survival. In the pancreatic, it doesn't go that way. So it's a hard place to go, not much to treat, and you don't gain much. So I think the third option is kind of redundant.
Well, I mean, one of the most important issue in pancreatic cancer patient is even the pain. I mean, one of the important outcome in those patients usually is
symptomatic
population. Mainly, I mean, 90% of those patients usually need some treatment just because they have pain. So it will be another important metrics. I mean, pain control. And I do not have any data regarding the IV in pain control. I don't know. Do you have any data on that?
We don't use ablation. We do neurolysis.
Yeah.
So,
also like on that again. So as you know, like the celiac plexus block is the answer, like neurolysis with alcohol. And we also know that like there's new tumor growth, new nerve growth, new pain, and these patients are like, that's one of the worst pain to have, deep boring back pain. And so my lab has come up with a new gel. I lead a device development lab also. So we have a new gel which we go and instill, and then instill the alcohol so that it retains. So the T-half of non-gel is about 30 days. About 30 days later, they start recurring with the pain. With this, we have brought it to 2.5 months. And hopefully very soon will be published. But that's, you raise a very important question because quality of life takes paramount importance.
This is one of, I mean, the most important needs of those patients.
I think I understand the pancreatic cancer would be a difficult thing and it will take its own time. So in the interest of time, I'll move to the next organ. It's on RCC. I think it would be for Dr. Ziva to answer this. What do you think? IRE has shown a good enough evidence to be used as a modality in the treatment of RCC compared to the cryo, ablations, all those. Means I'm thinking about non-thermal versus thermal.
I think just based on the evidence I show you guys, less than 200 patients in the world is not enough. We don't even know. We just. That's why I think the whole idea about us talking about is whoever does it, publish it, and then or if you see the problem is I think a lot of people if they do it problem solving, they probably do one or two in their practice as problem solving, then collaborate. That's why we decided to collaborate together. I think we need to seek great collaborations. And I think because of the nature of it, you will not be able to do RCT anytime soon. So the best we can do is cohort collaboration studies to get more evidence out there. And at some point, we can't even, at the moment, to do RCT in renal cancer, because whatever RCT you do at the moment, you have to compare with surgery. Until one of the thermal ablation becomes standard, like collision trial, we can microwave standard liver. Until we can do that, we are going to randomize against surgery, and IRE doesn't stand a chance in surgery.
Okay, so you partly answered the following question. The future also doesn't look good for IRE and RCC at least as of now. Okay, so moving on to the prostatic cancer. So I would wanted Dr. Govindarajan, anybody can take this question. So just the background about a prostatic cancer. As of now, in my setting, it's a high volume center for renal tumors and all urological. The urologists are pushing for a purchase of IRE. So they are into it. So background is that when you do a prostatic IRE, you don't need electrodes because you are very away from it. So it saves your time. Doing a IRE in a prostate is probably half an hour or 45 minutes job compared to doing elsewhere. So it's easy for them, so they are pushing for it. So now the question is, right now, prostatic cancer indications are very minimal, T1C and T2A. But why they are using it is, there are three things we are looking at it: functional outcome, safety profile, and local tumor control. So which of them would be a major driving factor to use it in prostate?
So you have been to our system, you have spent a month with us, so you know how our system works. We still feel that whenever we have to do IRE, we have to use general anesthesia and the room is blocked for half a day.
Yeah.
So, and you know, like we have 11, 12 rooms running, we are still behind like crazy number of cases. So the biggest challenge for us is to like broadly taking up IRE is how do we justify our time, usage time. So, and then that leads to the lack of IRE expertise in Mass General, as opposed to Govind's like system, because he had been pushing, he had been the leader for this since a long, long time. I would say like we still use it for very limited usage, and even in those, as I'm looking through my data in the last few years, we still go back to microwave, even in hard prostate cases. So okay. I don't think I'm the right person to answer this question. I hope Narayanan was here.
So just one more background. Recently, they have come up with a systematic review and a meta-analysis, which I have not included here. They compared with the other modalities of ablation for a prostate as well as surgical outcomes. One of the most important difference that IRE making is that the functional outcome means that the erectile dysfunction and urinary outcome is significantly less compared to the all other modalities, because as we know that it doesn't affect the extracellular matrix, so those kind of things. So when you compare to the surgical counterparts or ablative counterparts, IRE is performing well. So especially in those patients where you want to, where your focus is on a urinary incontinence or a functional outcome, they want to do a IRE. That's why urologists are pushing. That's why this question was. So it's okay. I think we'll move on. So I think Dr. Franco has already told a lot of things about the electrochemotherapy, but then as a part of my panel discussion, I did have this question. So two things. I think we all know initially started for superficial lesions. Now you have moved on to liver. Is there any plan of moving into the other solid organs to ECT? Do you see there is a scope for it? And the second question I have is, Americans have not started ECT compared to the Europeans. You have at least succeeded in starting this program. I have both Dr. Pereira, Dr. Franco. So
I don't know. I don't know the answer for the second questions. Probably one of the reasons is because the company who is producing the system is in Europe, and that could be just probably one reason. And yes, of course, the treatment has been used for many other tumors. We were using, before starting the liver, as you know, in the liver there's a lot of competitions. And I can say, microwave is now the standard of treatment for patients with metastatic primary tumors, no doubt at all. But before doing any kind of liver patients, we started using the ECT for bone pain palliations, and it seems to work a lot. Of course, it is usually for those patients without any other options. So they are patients who receive chemo, who receive radiation therapy. Very often it happens that they have a second run of radiation therapy. They usually is even less effective than the first one. So they are patient with any other options. And this is, when we talk about, this is a niche. But in high volume centers, this kind of niche, there's a lot of patients. And I can tell you, in the bone works, there's a lot of experience in AVMs or in, not cancer patients, but whoever they are patient with a
vascular malformations.
It seems to work a lot. There's some papers already published on a different. Someone also used the ECT for primary renal cancer, and yes, I don't think both the IRE and the ECT will be the techniques that we really need for kidney cancer, because we can almost manage every kind of renal cancer by ablation, both with cryo and thermal.
So I think we have European leaders, both Dr. Philip Pereira and Dr. Franco is here. So is there a way, the way CIRSE has worked out to start a ECT program, should ISUR also consider starting such kind of a program here for the create a scope for a ECT in India? Because I know that ECT is right now that the RESPECT trial, CIRSE is part of that RESPECT trial as an organization. Do we can create that same thing by ISUR? Is there a scope? Because, you know, otherwise when it looks at the economics, I don't think ECT will come India unless some society or some industry actively takes part to get it to India. So do you expect that to be a case here to start the program in India?
Interesting question, of course, because if I answer this question with your last question,
yes,
we have to talk about the definition of success in Europe for the introduction of ECT. I believe the big chance for ECT is in LAPC, in local advanced pancreatic cancer. As Franco said, as we understand from some talks, it's probably not the liver, because there is so many options now. It will be also very, very difficult to have an RCT comparing ERA with other thermal ablation. Yeah, it's even not possible to have a prospective RCT comparing with surgery, so it's limited. To be positive, I believe the big chance is local advanced pancreatic cancer. There is, I know you are a hepatologist or hepato-oncologist? Okay. Yeah, but I'm talking about pancreatic cancer. The new oncological data are with checkpoint inhibitor are better, or with combination are better than GEMOX. But we are talking about local advanced pancreatic cancer. We are talking from a couple of months, not more. So there is not really a new treatment, on a new systemic treatment. Surgery is not possible. SBRT is very demanding. You need a special equipment. As I said before, it's very difficult to recognize the tumor in the tumor infiltration. So you know what? Even what we see on MR or CT is not the reality. When you talk with surgeons, the lymphatic infiltration of local pancreatic cancer, and it's responsible for the pain, is going very in behind the tumor, so it's difficult. But using electrochemotherapy, you have a kind of improving the action of the effect of chemotherapy. You have a local effect, you have local regional effect. I believe if I have a message for the company is to look at this entity, instead not to look at other entity when there is so many competition.
Okay. I think we'll move to the next question. So it's again to Dr. Dinesh. It's on immunomodulation and combination therapies. So the question is, when you want to send the patients, do you think non-thermal ablations has only role in LRT, or there you see a combination therapy playing a role along with this either electrochemotherapy or a IRE kind of a thing?
So for HCC, in the context of HCC in a cirrhotic background, the current BCLC recommendations are mainly sort of mono treatments, like either you go for local regional therapy or immunotherapy. Within the local regional, we do SBRT or the TACE, like that. Having said that, there are trials coming out now where you give radiation first and then give immunotherapy. So what happens is, by radiation, it's a cold tumor, you convert to a hot tumor. For immunotherapy to work, you need lymphocytes into the tumor, the tumor microenvironment. To get that is to convert a cold tumor to hot tumor, you need some sort of inflammation and injury into the tumor. So that's what is provided by the SBRT. So there are trials coming out now saying with the combination of SBRT followed by immunotherapy, your immunotherapy response is better. But at the end of the day, this is all sort of either you can be used for downgrading the tumor or as a palliative care rather than as a curative. So the earlier trials, mainly based on the overall survival, has now in the liver world have moved into the curative option, because subsequently you can transplant if you downgrade.
Downstaging and the cat.
That's what is more.
So I think the part of second question was, is it going to make a meaningful effect? So I think we can come back is that maybe we can create a niche areas to use IRE as far as a combination therapies. As the SBRT and immunotherapy is there, so probably we can start IRE and immunotherapies, those tumors which we are not going to have an R0 ablation. In them also you end up doing this kind of ECT or IRE and then start a combination therapies. Maybe there is still a scope, that's what I understood.
Absolutely. See, the initial studies for immunotherapy is for palliative, that it's moving, the boundaries have moved, you know, from BCLC-D. We can use in BCLC-C and in B as well, because where if you have little bit multinodular tumor, multinodular malignancy, HCC, you can give immunotherapy and see the response to immunotherapy, see the drop in alpha-fetoprotein, and then give a washout period, and then you can transplant them. So that's where we moved into, whereas if you look at BCLC, immunotherapy is recommended for somebody with very advanced disease and you know, child P status, non-transplantable, like that. But now we are moving the boundary, so that's what we do these days.
Maybe a short comment and to open the discussion in another field. Regarding evidence in HCC, there is more evidence with radioembolization and systemic than with SBRT and systemic. And the only study I know is already published in case of relapse of HCC. It's a combination of SBRT plus systemic. So there is not so many evidence. Some studies are coming, as you say, but radioembolization, evidence of immune stimulation through radioembolization, and I'm not talking about complete radioembolization, we are talking about so-called radiosurgery. I don't like this wording, radiosurgery, but it's what we use, local, focal, segmental, or lobar radioembolization plus systemic. We have enough evidence with Atezo or BEV.
I'll have a comment on that. With regards to radioembolization followed by immunotherapy, the cost becomes exorbitant actually. So that's one of the areas where we find it, you know, the usage is a little lesser. So either they go for complete radioembolization or immunotherapy, but to combine both, it's a huge cost factor, whereas the radiation therapy comes at a little cost benefit. So this is quite important in a cost constraints.
Okay, moving on to the next modality that we have is histotripsy. I think I would want Dr. Ziva to take this question. Again, I think it's based on your trial, so there are 4 things, which patient selection and subgroups, and the other 2 are commercially, is it going to be commercially viable and does it have a future in India? Right now, because we don't have this histotripsy available in India.
So this is an interesting question. Basically, at the moment, the only indications that's FDA approved is liver. So so we did the CANE trial, which is feasibility in kidney. There's a feasibility trial currently taking place in Barcelona with a Ghana trial in pancreas. There will be, probably shouldn't disclose it, but there will be another system coming up shortly, but I think it's still embargo, so I probably shouldn't say anything. And in liver, I think that the indications, it's really difficult because in liver there are a lot of competition, but certainly a lot of patients now going for histotripsy are the ones that actually don't have any other options. Ever since we've taken part in the Hope for Liver trial, and I was part of the BBC CLICK thing, it really gone over. In fact, we have everyone in the world writing to us, but we don't have a system because after the trial finished. But our one of the site in Cambridge have a donation from Lee Ka-sing, for the billionaire from Hong Kong. They started a program. They have 500 referral almost, you can't deal with that. So a lot of patients are not suitable. So certainly in my experience at the time, you have to evaluate a case. we actually divert a lot of patients to US for treatment for UK. A lot of patients travel. As I was sharing, one of the patients with 20 liver mets have 4 lesions treated, and then the rest now went in remission. And there are some patients who have cholangiocarcinoma that we would not normally treat with anything, that they actually go on the history, and this seems to be surviving, but we're talking about case studies here. So I think that we need to do more research and to define indication. In the UK, there is the NIH have appetite to look at indications and evaluate properly, but we don't know when that's going to happen. Certainly for renal, we have to watch the space for the hopeful kidney trial, and depending on what FDA say based on the results. Pancreas one's quite interesting because I have heard some of the talk, and I also have direct communication with the
Not
PI.
much of a data.
So yeah, we don't really know. So what is it going to be commercially viable? I think this is a very exciting technology because, but at the moment, we are actually very early on in the translation. So, I mean, we never really get to translate as early as this, but so it's very exciting. But I think there are a lot of iteration of the technical innovation. I think, I have to say, it probably have some interesting indication, not just in liver, but in other part of the body. And I think that time will tell. I think it is very exciting times ahead. Certainly, for patients we try to enroll for renal tumor, kid you know, no one turned it down. In fact, I have to turn a lot of patients away. They're more disappointed. No, I told them I don't even know if this works, but nobody want to turn it down, which is really strange from my perspective. Because I didn't want a patient to accuse me of using them as a guinea pig, but they wanted it. You know.
I think now Shams, can you add? Already you have said so many things about the histotripsy in the previous talk. So anything else you want to add?
No, I will just answer the question in a very succinct fashion. So the tumor patient selection is like it's related to all the 3 points. Let's just look for the 3 patient subgroup. Liver, kidney. We are the part of Hope for Kidney trial, so we are doing that. With the liver, for that, for the trial, they gave a machine. So we have that machine. Then we bought another machine. The surgeons bought together with IR. And we had been doing liver. But as I mentioned, after 13, there was a huge break. And we were about to start pancreas, but then we stopped because we are really seriously evaluating. And the future available data is that's where we are working towards. Commercially available is the most interesting question because knowing the whole company, I know the whole team there, they are so aggressive. It depends on which way you look. You're looking at from the IR side, or you're looking from the patient side, or you're looking from the company side. From the company side, they'll most likely succeed because from the business world, it's all about the team, and they have an amazingly aggressive team. They don't care who buys it, and that's what reflects in the fact that they have sold 75% of their machines to the surgeons who have no clue about ablation. And that brings to the point of the patient selection because they have been marketing. In the US, you can market stuff. You can do ads of medications and machines. So they have done such a great work that we tend to get just a lot of emails from patients and reaching out, please help us out. But the problem is they are non-ablative candidates. And they are sold on the abscopal effect by the company so hard that they say, oh, doc, just treat one. I'm like, no, you're forcing me. And I can't, if something goes wrong, I can't defend a $10 million trial.
So I'll give
So it's a very complex environment. I would say in short, a TBD, to be disclosed.
I think I had an input from Dr. Mukta also. So she works in Apollo centers. I think the clinicians are interested. As you said, surgeons and clinicians are more interested in histotripsy at present than the radiologist.
They're using the back route. So we are under pressure, and if we tell the right data, we are the bad guy. Hey, you don't want to do it? No, because we don't want to do it because it's not right. So that's where we are.
And in terms of marketing strategy, I mean, they are absolutely in the right way because they are approaching who is owning the wallet. This is, a typical strategy for big companies who want just to sell something, and even because usually surgeons doesn't have the knowledge for taking care and follow up those patients. So they don't care to have patients, and so they can try.
And they
so,
open.
Yeah.
They're back at if they screw up, pardon my French, they're open. For us, we have to be absolutely correct.
So I think I probably had to change these things. Histotripsy, who benefits today, whether IRs or clinicians, probably. That's how the question should have been looking at it. Okay, let's move on to this thing. So this is an important question because we already started IRE, as Naveen sir said, we started in 2016. It's been 10 years. Since 10 years, only 3 centers in India have it. So now the question I would bring to sir only, how to establish, there is a follow-up slide which also looks at how to propagate. So please, you can take up both the questions because that's also important that we need to increase the number of centers who do IRE.
Yeah, so first and foremost, I think as IRs, we need to know where IRE fits into our system. What are its goals and what are its selection criteria? So once we are sure of that, then we have to look at the wider spectrum of our patient referral that we have in our centers. So looking at some points have been raised for, some against. So I'll list some of the against points. The time takes a lot of time. Table time is there. You have to need general anesthesia for it. So, but then you are working in an environment where it is successful in structures which are very vital. So that's a niche area. So we have to be sure that it fits into our entire spectrum of referrals that we have at our center. So initially it's going to be the tertiary care centers which have more volume of work, which should be going in for IRE as a modality and adding it to their existing ablative other modalities, right? So once that is there, then the second thing would be the cost of the machine. That's also, upfront. That also, the management has to be on your side. So they have to be working in that way that the economic viability has to be worked out in the center. And as a society, I think we need to do more pooling in of data from more centers that already are doing it. So we have 3 centers, so we can pool in data and look at more multi-centric data generation to have more scientific data so that others can rely on it and convince their management that this is the right way forward for some niche applications. Another thing is that the industry, I'm sure the R&D would be working at the back of their mind. They also know that at present it is only a tool which is going to complement other ablative modalities. It's not going to replace. And they also know the reason for it. The reason being it's a multi-probe solution. So once they know, I'm sure they were working at one time, but whether they now are still at it, I really don't know. So would be a one-probe solution. So there are, in fact, prototypes coming from Southeast Asia. So recently at ACTA, the Koreans were looking at already a multi-probe solution, though I'm not sure how well or bad it's going to work. They said they had presented the data at SIR. So where there already comes as a 2-probe or a 3-probe solution, where you don't have to worry about their convergence or divergence of the probes. But I think the challenge there would still be getting across the structures on the way if you have multi-probes. Like the cluster probes was always a challenge when we used to do RFAs, right? So we were always, it was technically more challenging. But then there are, R&D has to work more in it. So I think at cryoablation, at one time it was written off as a modality. But it came back with a bang because of the changes that they did in their system, in the probes. So still it is back in the reckoning as an ablative modality. So I think it would be very apt to think that IRE is definitely there to stay, but we need to know the niche areas where it's going to work. And obviously, it won't be a knee-jerk reaction that I have microwave, I have RFA, I should buy IRE. It's not going to be like that. We need to plan how IRE is going to get into the system. It's more important for India considering the financial constraints. So as I said, as a society, we can work for pooling in of data, getting more, trying to work more into areas where the application would be easier. Like TMH, I think somebody from TMH can comment. They are working on soft tissue tumors with IRE as well, in addition to cryoablation. So there are applications where we can work. The gallbladder, as our center is looking at. So there will be work and applications for IRE specifically. And I think it's definitely a good modality to work with. The steep learning curve is there, but once you're at it, even your procedure time drops considerably.
You want to take this?
Maybe a first conclusion. We need, for IRA, sludge, ECT, we need a clear strategy. Pooling the data is a good idea, to have
registry
preliminary result to see where IRA ECT may play a role. Point 2 of the strategy is to put together experts, to put a steering committee, and we can do that with, in a cooperation, CERSE, IAS-VIR, and ISIR maybe, to pull the data easy, to discuss on that, and to find out first which organ, which tumor, and to put a clear study. It should not be a randomized clinical trial at that stage. It's too early. But to get prospective control or non-control result with IRA or ECT is the only way, because you can continue to publish observational data, retrospective data. I mean, in an oncologic world, you will never get a place at the table. Yeah. So that's a clear strategy. Steering committee, no more than 10%, in my opinion. More than 10%, you will never get out from the discussion. Multidisciplinary is important. I don't say that because we have an hepatologist here, but I think I was ECIO chairman. We have a really multidisciplinary approach, and should be multidisciplinary. Nobody of us, not you, not the surgeon, nobody had alone the solution for cancer patients. So multidisciplinary steering committee discussing, because there is some good possibility and promising result with IRA ECT. We don't talk about costs, etc. coming later. First, clinical evidences.
Can I ask a question?
Yeah, please.
With electroporation, is it likely in near future that we have an equipment where we can have two modes, reversible as well as
irreversible?
We are just applying voltage in both the modalities. So what is the difference in the physics? I don't know. And second question is, has anybody thought of injecting bleomycin in patients who are undergoing IR? Because even there we are having damage, cellular damage.
I mean, it is just a matter of voltage. It's just a matter of voltage, because I mean the machine who may perform IRE could also perform ECT. ECT could have virtually an advantage because has a double effect. The mechanism is electrical and biological, thanks to the bleomycin. And that's the reason why the idea is just to, to treat the lesions together with the periphery and having a clear margin rather than IRE. And however, regarding the indication, I don't want just to repeat the same things they already said, but I think this is those technology that may be really helpful in those high volume centers when you, for instance, I do have the same experience of him. We do a lot of thermal ablation, a lot, even too many in my mind. But very often it happens that you meet a patient or oncologist or surgeons send to the patient you don't want to treat with ablation because you have experience with the very badly complications after ablation. In those patients, those technology may be very welcome. That's my point of view. This is a little bit different than what happens with this trotripsy. Because I think, IRE and ECT may complete the possibility to treat all lesions in the liver. I cannot see, according to my experience I have with the HIFU for more than 10 years, I cannot see the real advantages of isotrypsy in the liver, unless it would be something that may give some psychological benefit to the patient that want to be treated. But again, the difference between the technology is just voltage, and the indications again just those patients without any options.
I think in the interest of time, this is the last slide. So it's a rapid fire. I need a one-word answer. The first question is for all of you. Which organ would you prefer IRE in? And why? Why means whether it is safety, efficacy, or outcome. So I think Dr. Franco, you can take the first question. Which organ out of all the organs, where would you prefer and why? Whether is it because of the safety, is it because of the efficacy, or is it because of the outcome?
I already answered.
Pancreatic cancer.
Dr. Z.
By the way, for next year, we could discuss IRA in the lung.
Oh.
Actually, it's very interesting. I think out in pancreas is the area,
Okay.
but actually in the UK, the only area that is commissioned at the moment by the government is in prostate.
Sir, for you.
I think I won't opt for any particular organ, but I would opt for, if you want, stressing it, I'll do for liver and pancreas growth.
Okay. I think then I'll skip the next question. I'll go to the third one. One indication where you think histotripsy or electrochemotherapy would outscore the other modalities in future. Dr. Franco and Dr. Pereira. As far as non-thermal ablation or ablation per se is considered.
Yeah, when you cannot do ablation. Yeah, again.
I heard it.
You can treat the patient safely. And I can tell you even more safely than IRE. That's because, I mean, in all the images you can see immediately after IRE, you can see the air bubble through the track of the needle. That's because there is a thermal effect of the needle. You never seen this kind of effect after ECT. Never. So I don't know. We do not have any data comparing IRE with the ECT. This is just my feeling.
So it's hard to say like it can do enough that it beats the standard modalities. Very hard. So
I think evidence is not enough as of now.
I think
so we
like,
just have to wait and
5
watch.
years, if not longer, away from talking it in a serious way.
Please, Dr.
Can I just add a line? This is the first time I'm hearing this terminology. Okay. Okay. So that means even last week there was International Liver Cancer Society Association meeting held for 3 days. We never had talks like this. So that means there is a big gap between the clinicians and the interventional radiologists. I think that we should know what's going on. You know, without that, it's very difficult to say, okay, because we only know the conventional stuff, what's going on already. Anything new, we wouldn't know unless it comes from you guys.
But this is a cutting-edge technology, so I mean it's absolutely normal that oncologists, clinicians don't know nothing. I mean, think about 25 years ago, no one was talking about clinicians about RFA and the liver. So, and I guess there would be a lot of hospitals where clinicians still don't know about microwaves in the liver that is going to be a standard treatment. So it is normal. This is cutting-edge technology.
So that's what I'm saying. For you, this is normal cutting-edge technology, but for
this
us,
is not normal. This is cutting-edge
not normal.
technology.
Okay.
So we are talking about the indication and the space for these technologies in a clinical setup.
Yeah, but unless we work together,
but
just
we still
saying,
don't know.
the right patient selection is very important here. Sure. So
Okay, I think we'll close this.
Maybe if I may, it's an interesting
please.
point.
Last point.
Maybe you have a problem, interventional radiologists. We almost never publish negative result.
I think I'll answer that question later personally to
what
Dr.
you did, when you have negative trial, you publish this negative trial. So maybe it should not be the conclusion, but maybe we can think about that.
What Philip already mentioned, just like 30 seconds. Cross collaboration is the answer, and that's what I see you are also alluding to, which is like should be at the society level. You should interact and talk among each other and invite each other, and that's how we can grow together. That's what I would say.
I think I would like to thank all the panelists for your time and your knowledge sharing here. So thank you all. I think.
Thank you all.
This will be a very fundamental talk on neurolysis in managing chronic oncology pain. Right, so just introduction on pain. Pain is defined as an unpleasant sensory and emotional experience, and it's difficult to diagnose and treat, hence interventions often fail. In malignancy, and incidence and severity of pain is variable depending on the type of malignancy, and majority of cancer patients in developing countries present with advanced disease, and with pain management and palliative care are the realistic treatment options for such patient groups. Usually pain originates from a variety of sources related to tumor or treatment, and there's no relation to the underlying oncological process. Any pain in a patient with previous history of cancer should be considered as recurrent until proven otherwise. And most of the time it is inadequately managed as a result of many patients spending their last day of their life suffering with great discomfort and disability. And cancer pain dramatically affects patients and their families. Effective control of cancer and cancer-related pain is thus important. So introduction to my talk will be on various therapeutic modalities for addressing cancer pain, and which can be classified into three major categories, whether it's specific anti-cancer treatment intended to eliminate or decrease the size of pain-causing tumors, for non-invasive procedures, and with image-guided minimally invasive procedures. Again, so it's the specific anti-cancer treatments intended to eliminate or decrease the size of pain-causing tumors, such as radiation therapy, chemotherapy, include hormonal therapy and palliative surgery, as well as thermal ablations. For non-invasive procedures, include administration of systemic analgesic and related drugs, psychological techniques, neurostimulation techniques, and physical therapy. Other image-guided minimally invasive procedures include a regional anesthesia achieved with local anesthetics or intraspinal injection and narcotics, prolonged regional and analgesia achieved with injection and neurolytic agents, chemical ablation, cementoplasty, and so forth. Again, pain assessment is essential prior to embarking on a pain intervention, and usually I only intervene when patients' pain score of more than 6. So the WHO actually presented with the initial preliminary 3-step analgesic ladder in 1986, where if pain worsens, actually the treatment was a step up with initial initiation of non-opioid analgesics, followed by weak opioid and strong opioids. And most cancer pain usually can be treated effectively with opioids alone or in combination with non-opioids, but not all pain is alleviated by this approach. And thus, the 4th step in the World Health Organization analgesic ladder was then introduced. And since then, actually, the interventional treatments were a mainstay of management of chronic cancer pain when strong opioids failed. And this is in the reverse as compared to acute pain, where interventional treatments were the first line of treatment, followed by strong opioids and weak opioids and so forth. So as you can see, this has been published very extensively by multiple centers, especially in the many journals. And as you can see, even then, the use of interventional procedures for cancer pain, a brief review that was recently published in 2024, also advocated that cancer pain is something that needs to be addressed comprehensively and effectively. And this interesting journal that was published in the pain management by a nursing team actually did conclude that with more specialty physicians educated in performing innovative interventional pain therapies, access has increased for all patients, including those with limited access in the past. However, the final piece of increasing utilization is for all healthcare providers to consider interventional usage earlier in the patient's disease process. So understanding pain is important prior to intervening, and you need to know where the source of pain is. So whether it's a visceral pain, where the characterization of the pain is whether it's more diffuse in pressure type or sensation, it's poorly localized, however it responds well to exogenous or endogenous opioids. Somatic pain, however, is different, where it responds well to exogenous or endogenous opioids, and in neuropathic pain, the sensation of the pain is more of a burning, tingling sensation with laxinating component, where you may have features of sharp stabbing, shooting, or cutting pain. And these may respond to several interventions, whether via nerve blockade, spinal cord stimulators, and alpha-2 adrenergic agonists. Regional anesthesia with neurolytic blocks usually is achieved quite sufficiently with alcohol and phenol, which is what my mainstay is, and I've been using that for some time, and it works quite well with the ability to interrupt the nociceptive pathway for weeks or months. And absolute contraindications to nerve blocks include abnormal blood clotting, infection at the site of the injection, or allergies to relevant drugs. General complications, of course, can occur during any neurolytic block, and an excessive dose or accidental intravenous injections of local anesthesia can cause systemic toxic reactions. And these can vary from mild vertigo to severe complications such as convulsions, coma, and severe hypotensions. Prevention always is to utilize the lowest concentration and volume of local anesthetic drugs, repeat aspirations during injections, and to, of course, administer a small volume of contrast given intralesionally prior to anesthetic drugs or ethanol. So these are some of the patients that present to us in palliative side, and you're thinking that, and this patient had very severe sciatic pain with a tumor actually infiltrating into the spinal canal. Patient was actually deemed, this was a patient with diffuse METs and was already deemed to be on a palliative care. And the patient was suffering from severe pain, and we were thinking how we were going to address at least alleviating the patient's pain. So we tried doing an interlaminar epidural approach, of course, localizing a space where you could infiltrate with your local anesthesia was difficult. So we sort of just identified the epidural fat pad at the posterior area, targeted that area, and injected a bit of contrast just to see where it was going, but it actually was quite fixed at that area. So the key is not to give up and try any other approaches, and so we tried a transforaminal approach, and here you can see there was a sliver of contrast actually flowing into the epidural space, and with that actually the patient got significant pain relief post-procedure. So brachial plexus blocks are neurolytic blocks to the limb in metastatic plexopathy and should be avoided because it produces an almost useless limb. However, in patients with excruciating pain in the upper limb caused by plexopathy, in whom oncologic therapy is no longer effective and who have short life expectancy, paravertebral blocks of the involved roots of the brachial plexus should be attempted. And this injection should be preceded by a block test, dilute with long-lasting local anesthesia, diluted with contrast medium to alleviate the severe pain that occurs from use of neurolytic agents. So this is an example of performing a CT-guided brachial plexus block that you can do under CT quite effectively. So moving on, sympathetic chain blocks, and the sympathetic chain is located along the vertebral column, and it carries much nociceptive information. And sympathetic blocks may improve actually visceral pain and sympathetic mediated pain. And the progressive infiltration and compression of nerve roots, nerve plexus or peripheral nerves by an enlarging tumor produces radiculalgia and neuralgia, which is often constant and burning in character. So again, patients may present with either nociceptive pain and neuropathic pain, and differentiating these two pain features are important prior to deciding on your route of treatment. For a thoracic sympathetic block, the ganglia is located in front of the heads of the ribs between T2 to T8, and the pleura is immediately in front of the closely related ganglia. Neurolysis can be used in patients with severe intractable pain caused by carcinoma of the esophagus or other tumors involving superior 2/3 of the posterior mediastinum. As you can see, you can actually intervene by introducing your needle just here, and you can identify actually the ganglia actually next to the head of the third rib as depicted in this illustration. Again, performing a lot of these blocks under CT is very effective, and you are able also to, once you have infused with contrast, you're able to also see the contrast flow along the ganglia. Lumbar sympathetic blocks, again, the chain is located close to the anterolateral aspect of the spine, and these receive nociceptive information from the lower ribs and ipsilateral pelvis, and usually indications are for PVDs, sympathetically maintained pain such as CRPS, treatment of hyperhidrosis, amputation, stump pain, phantom pain, and intractable urogenital pain, as well as pelvic malignancies. And sometimes a single needle approach can't be reliably achieved, where then you will have to employ a bilateral needle approach. So these just some illustrations of how I do my sympathetic chain block, and this is a single needle approach, and here this patient had more left-sided pain, and thus we only managed to get away with just a single needle approach. Cervicothoracic sympathetic or stellate ganglion blocks used for tubal infiltrations which compress and damage the lower part of the brachial plexus, often referred to as the superior pulmonary sulcus in Pancoast syndromes, and produces pain initially to the shoulder, scapula, and posterior aspect of the arm and elbow, with other symptoms as well. So again, sometimes you may even employ performing some of these blocks under ultrasound. So this is a sonar anatomy illustration of how you would perform an injection of the stellate ganglion. As you can see, the stellate ganglion is located just behind the carotid artery and the IJV, and just in front of the longus colli muscle, and just anterior to the anterior tubercle. And you can actually achieve a significant block just under ultrasound. But I prefer to do all my injections under CT, and you can see here, you just target the anterior tubercle at C6 level, and you're able to get a good neurolysis. Again, celiac plexus and splanchnic nerve blocks used to eliminate drastically reduce excruciating epigastric pain. You may perform an anterior or posterior approach. I prefer a posterior approach, and you can see here, sometimes you will need to use a bilateral approach. You may need to maneuver your needle against a lot of the vessels. This is the aorta, so you want to make sure that your needle is anterior to it so that you can get a good spillage of contrast. And you should see that the contrast should communicate between the left and right side to get an adequate ablation zone. So conventionally, a lot of these procedures were done under fluoroscopy. I still don't know how they do it under fluoroscopy, because I get palpitations trying to to puncture through the aorta and to access areas like this when we have CT, and it's so easily available and more easily to be performed under CT. So again, complications can occur in any procedure. Orthostatic arterial hypotension, where treatment is intravenous infusion of fluids and intravenous injection of small doses of vasopressor. And avoidance include assume the upright position slowly from the table for the following 2 weeks, and complications sometimes include intractable diarrhea. So again, cancer pain is, going on to a pterygopalatine block. So these used for mostly for craniofacial sort of cancers usually, and this works quite well for some patients who have really bad head and neck cancers that infiltrate into the plexus. And my final slide again, just to conclude, cancer pain is debilitating with role of neurolysis can be used to reduce and control the degree of pain. Important to identify causative pain generators, and it should be incorporated as the 5th vital sign, with all cancer patients deserving a pain-free life. Thank you.
Thank you. Really appreciate it. Any questions? If not, I have just one technical question. Do you guys? I saw most of your needle were like straight trajectory, and it was a little challenging. Do you have Morrison needle by any chance, where you can curve the needle? It makes life very easy.
I don't, not in my center, but I so far I've had no problems actually getting good distribution of the alcohol with a straight needle trajectory actually.
If you have that, you'll thank me.
Okay.
We do a ton of those.
Right.
And it's a very good troubleshooter. Like instead of finding the right target, it's much easier. You just go in, curve it in.
Okay, wonderful. Thank you, thank you.
So Franco, I think is.
Thank you, Dr. Naveen. We now invite Dr. Franco Arce to speak on percutaneous ablations, practice-changing trials, and what the future holds. Thank you.
Can you tell me the name of the angle needles? Okay, of the Morrison. Okay, okay. How big is in it?
We have 21 gauge and 20 gauge.
21 gauge?
Yeah,
Okay, thank you. Okay, thanks. Yep. Double click. And this one. Thank you. Okay, thank you to be here at the very, very, very late time. I mean, according to the title, you can imagine I'm going to talk about very exotic and futuristic devices, but that's not true. I mean, we know that what we are doing with the ablation is amazing. It is one of the most scalable curative intent tools in IO. It is especially true for the liver. After many years, unfortunately, we still have some issue in having reproducible surgical-like outcomes. And the gap of these issues is not just because the technology. So, I mean, we were discussing the new and cutting-edge technology up to half an hour ago, but I mean, one of the main issue is just the lack of standardization and metrics. And so there are some practice-changing trials now are defining our benchmark that could be very useful for the workflow and even to compare any other application. The background is that even after many years, the European Society of Medical Oncology clinical practice guidelines for local treatment or metastatic liver disease from colorectal cancer. The radiofrequency ablation, that is, I mean, they don't talk about microwave. They specifically talk about radiofrequency ablation because the majority of the data are coming from very old papers already published. But the indication just again in unresectable colorectal liver mets. That is one of the most important bias in our daily practice. However, this is the reasons why the indication is lacking in the ESMO guidelines. That's because there's an absence of randomized clinical trial comparing surgical resection with a non-surgical disease. And for this reason, surgery has remained the standard treatment approach for those patients. And the difference reported, so the gap reported between surgery and ablation is mainly due because there's very usually no mention on safety margins. That is, the R0 is the Saint Graal of surgical resection, and that is a big problem with selection bias. But we know, I mean, if we want just to compete with our colleagues, liver surgeons, we need to talk the same languages. I mean, the benchmark is, of course, the surgery because it has been used since 1 century, even more. I mean, surgery exists in our world since 2,000 years. So we are, I mean, just in the infancy as IR. But I mean, the goal of any resection is achieving the R0 margin. So if we started to talk the same languages, we need to have the same goal. That is achieving an adequate minimal ablative margin. So the MAM concept will enable reproducible comparison with the surgery. So this is, I mean, a perfect patient that I treated more than 10 years ago. At that time, we just put the needle and ablate, and then we saw what happens with the CT. I mean, she was lucky because, I mean, after more than 10 years, she is still disease-free. But this is something that we don't need to do more because now we have, data coming from such important clinical trials already closed with a lot of data that we can use just for make a tuning of our daily practice. So I would like just to mention the CMR. There's a European study. It is an observational registry. You probably know has been now it's closed since 1 year now. It was including patients with metastatic liver disease up to 9 lesions, up to 3 centimeters. Probably you know much better the condition trial that's been published, and now we know that in this randomized clinical trial, comparing surgical resection with thermal ablation, the thermal ablation series performed as equal as surgical resection, but much safer, in a much safer way. And then we have the ACCLAIM trial. The ACCLAIM trial is, again, an observational study. It is an American-European study with the purpose to evaluate microwave with confirmation software as a potentially curative local treatment for a patient with colorectal liver mets. So this is the data that you know coming from Collision. As you know, the enrollment closed earlier, as has been mentioned before, because they met the preferred criteria for non-inferiority versus resections. But in the meantime, thermoablation compared to resection was substantially safer in terms of morbidity and mortality. You can see outstanding overall survival. 1 year overall survival is absolutely the same. There's roughly speaking around 93%. And but more important, if you take a look on those patients has been treated with navigation. That it means that they don't just stick the needle by using just one modality, imaging modality, but at least 2 different modalities. And you can see, and also using software, confirmation software, there's a gap in terms of local progressive-free survival. And this is absolutely the same curves you can see in the CMR. And remember, CMR is a real-world observational study. And the more important, I mean, the 1 year overall survival in CMR is even better than Collision. I don't know why. It is a real study, real-world study, but however, even in the overall survival, there's a big difference if you try to understand those patients, to divide those patients who receive an ablation with more than 5 millimeters safety margin compared to the ones without this safety margin. Going a little bit deeper in details, you can see that, of course, this is more than the intuitive. The lesion bigger than 2 centimeters have more chance to progress. But the usage of confirmation software is mandatory at this stage because we can really keep going to treat our patient intra-procedurally until we may achieve at least a minimum safety margin of 5 millimeters. You can see the difference. If you achieve less than 5 millimeters, 25% will progress. Another important point, you are no more allowed to treat your patient just using ultrasound alone. So not just because you need a CT scan for using confirmation software, because you need a CT scan before, a CT scan afterwards, but even because ultrasound alone is not enough for giving you the feedback of the real local outcome. Then the ACCLAIM. I mean, ACCLAIM is recently closed. We participated to the ACCLAIM study, so we do not have any data. We still don't know any data. However, the hypothesis in this amazing trial is that microwave ablation in lesion up to 2.5 millimeters, only patients with up to 3 lesions were allowed to be treated in this trial, with confirmation software of ablation margin, may achieve definitive local treatment control, so can be defined as local cure as well as resections. One of the strengths of this trial is that it's raising the bar of thermoablation in our daily practice as a standard of care local cure in colorectal liver mets. It will create a paradigm shift for image-guided percutaneous thermoablation, and at the same time, it will set a template of a sort of validation and clinical implementation for any future ablative technologies. This is what I mean when I talk about intra-procedural confirmation treatment and confirmation. So we need the baseline CT, navigation means using more than one guidance tool. That is, could be CT and ultrasound infusion imaging technology, or using CT-HA. That is the same technology that's been used in some center in collisions. Then you ablate. Immediately after the ablation, you need just to have a new CT scan to be sure that the data set that's been sent to the confirmation software are enough to confirm that the safety margin are okay. Otherwise, you can just keep going, ablated those parts of the lesion that are not receiving enough safety margin. This is a typical example. This is one of our patients. You can see here the lesion is not very well seen. It can happen with metastatic liver disease very easily. The lesion seems to be, treated because, we reach the boundary of the vessels, as you can see here, where we send the data set to our confirmation software. And as you can see, the confirmation software told us there's still some viable tumor. So we took the advantage of ultrasound CT fusion imaging navigation system. So we placed the 2 digital markers here where the tumor was still viable. And it was very easy, just in real time, to stick the needle using the digital marker as a target, just to stick the needle there and keep going, ablating the tumor. And this is the end of our approach. So in our software, there's no standard outcome in the software. Our software, class 5, means that you reach at least 5 millimeter margins. Of course, there's still some yellow dots here, but this is immediately, on the vessels. This is still one of the issues. So this is the crucial role of imaging in ablation. We have a virtuous circle that we need to respect in order to achieve amazing data that we can compare with surgical resection. So I don't want just to waste your time. Of course, we need some metrics as quality indicators. They may give us the chance of reaching the surgery-like benchmarking. Ablation can achieve, now we have data, the outcomes as good as surgical resection in selected patients, of course. We are dealing with a lesion up to 3 centimeters or more. Of course, ablation has a limitation in treating a lesion bigger than 3. Advanced navigation techniques are so critical for an accurate targeting and optimal treatment delivery. Again, ablation confirmation software is something that we cannot avoid to have in our lab if we want just to deal with this disease. Ultrasound and CT alone, again, are often not sufficient for having a precise guidance for liver ablation. So we may take advantage of both the 2 imaging tools together. Fusion imaging is one of the possibilities. Otherwise, arterial catheter-guided CT would be another one. And however, multimodal imaging nowadays, I think is mandatory for achieving good results. What about the future? I don't think the future will be an improvement on our needles, on our energy. According to this data, the near future means just to push all the centers doing ablation in colorectal liver mets to follow the recommendation coming from data that's been come out from the trials. So probably we will have an improvement in the multimodality integration guidance system. We need to standardize ablation technologies and techniques, improve margin confirmation software. Nowadays, thanks to AI algorithms, they are a little bit faster than in the past. I'm working with a confirmation software since 5-6 years. At the beginning, we were waiting even 45-50 minutes with the patient in the room, waiting for the margins to be sure that everything was okay. At that time, we were okay, however, because it is almost the same time, a little bit longer, that the surgeons are usually waiting after send the specimen for having the Fritz histology. Driving decision support and predictive modeling and robotics, as well as stereotactic navigation, will be other important improvement in this field. Thank you.
Thanks, Franco. Great presentation. You want the mic?
The Philips, the cath labs are also providing conformational software for radiofrequency ablation or microwave ablation, where you put the data of the CT scan pre-procedure of the patient, and on the plane scan you take the cone beam CT. You have any experience how good it is? Or
I do have almost the same coming from Canon. I do have the 4D CT Alphanis Canon coming from Japan, and they have an embedded. This is non-elastic, and this is one of the big limitations of the previous confirmation software. I don't know about Philips if the system, if the software is elastic or not. But it's important that the system will be elastic, because you need to consider the deformation of the liver, even according to the position of the patient, because very often it happens that we need just to tilt the patient, and a lot of confirmation software cannot recognize the segmentation of the liver if you change the position. So at the beginning, we needed just to maintain the patient at the same position, pre and post-ablation. We do that with a vacuum mattress, so we can block the patient. Nowadays, with the AI, it is something that is completely changed. It can be overcome easily. They don't care, I mean, their software don't care how the patient is located, because according to the vascular pattern, according to the segmentation of the bone of the liver, he can perfectly overlapping the pre and post, even if the patient change the position on the bed.
Yeah, thanks, Franco. So let me just reiterate what he mentioned, because during I did a year of research when I went to US, and my work was in stroke, and my primary job at that time was co-registration, and which is what the challenges which we face. Basically, they have to overlap two CT scans. It's very challenging, and this was like about 15, 17 years ago. But now with AI, it has become so straightforward that it's really, really easy. So, and it should be like, it should catch up with the problems.
There's still some issues, there's still some limitations.
There's a learning curve, as I was saying. There's a learning curve, and I cannot emphasize enough what Franco just mentioned, that like, we need to work at the R0 level. No surgeon will ever do a resection without having the whole segment, or if they're doing partial, they have the edge checked by like my pathology at the time. We don't do that, and for the longest amount of time, we got away with it. But I think right now we are challenging with the collagen trial, we're challenging surgery, so we need to be at that level to talk, and then only we'll be accepted. So.
And I can tell you, we can be even better than surgeons, because it is not surprising me that after an R0 resection, we may have relapse. And that's because, if you're familiar with the resection, liver resection, they are not precise as they are intended to be. We could be more and more precise than surgeons. That's because they need to translate the imaging into the real world. And they cannot see what happens inside the liver. They only can see around the liver, the surface. And even the smarter liver surgeons who are using the ultrasound-regulated resections, they do have still a lot of biases in maintaining the same plane they planning before on CT images. For us, it will be much easier to be very, very precise, much precise, because we don't need to translate the images in another field. We need to maintain the images. We are treating images.
Yeah, perfect. So that reminds me of a point. Like we just got published last year in 2025 our experience of intra-operative ablation. So this is pretty common because we have a very high volume center. So every now and then, what Franco was mentioning, they will go in, and they have the hockey stick probe, and they'll look at it, they're confused. So they call us. So we ended up looking at the last 10 years, like how often that happened. There were like 21 patients, and we published that. So he's right, like they have everything open, but they're confused. We are extremely advantageous position of being the way we see the organ with imaging, and imaging in the future. Like even surgeons, if they don't mold, they will perish. If they mold, we'll be struggling. But whoever has the better control of that will win. That's pretty much the story, I guess. Thank you.
What is the mean number of tumors that you ablate?
The maximum number?
Yeah. In a session, what is the mean number? Like maximum is, I saw that 9, 10.
Sit down. 11. 11.
Maximum is 11.
It's 11, yeah. We did 11 in one session.
He was asking the mean, like if you look at the last year,
I can imagine.
average.
But it was, the average is usually no more than 2 or 3. Yes, usually we selected the best patient for sure.
And the patient,
but it was, 11 just was not for colorectal liver metastatic disease. It was just for neuroendocrine tumors.
And the procedure time is typically 1.5 hours?
Pardon?
Procedure time. Procedure time.
Long. Very long.
No.
Very long,
Like-
even because,
so it is
we
like
do,
surgery then.
because we do, yes, of course. But this is not a matter of time. You have a patient. Come on. You have not just to be fast. You need to be effective.
Exactly. It's the cure, not the time. I know we are like obsessed with speed. We are obsessed with speed. But that's where we don't want to play. If you play that game, we lose. Because 2 out of 20 recurs, we lose.
I don't want any pressure by any other colleagues that I need just to move out because they need the machine. That's the reason why I have my own CT. Do I have my own technologies? And just to be clear, since 25 years ago, I'm using general anesthesia in all ablation. So all patients are sleeping.
Thank you. Yeah, so like we have 5 CAT scanners, 3 in IR, 3 dedicated to ablation, 2 for biopsy drain, whatever else. So that's how we get the ball. Like you can't be pushed. Thank you, Franco. Appreciate it. Yes. Franco, you want to take this or should I? So, neuroendocrine tumor, what's the maximum size you can ablate? 3 centimeters. I prefer neuroendocrine, I just embolize. Like I try not to ablate. Because we know for a fact, again, we go into tumor biology. By the time you see one lesion, it's a given fact that you have multiple other lesions. It's just matter of time. So we keep treating it. We used to do Y90 in the past, but we stopped after Lutathera. So we saved the radiation effect. We just do bland embolization. Yeah. Thank you.
Thank you, Dr. Franco Orsi. We have one last talk before the panel discussion. So we would like to thank everyone for being accommodative of the delay in time. We invite Dr. Suraj Bhame to talk on strategies to overcome ablation-induced nerve injuries.
Coming to the last. So, good afternoon, everyone. I'll be talking about the strategies to prevent ablation-induced nerve injury. So, before going into the strategies, we need to know how the temperature reacts with the nerve. So, safe temperature, what we talk about is between 10 to 45 degree. That's the safest range where a nerve can survive without having any damage. But when we go on the higher side, 45 to 60, there will be neuropraxia, which will present in the form of temporary nerve dysfunction. However, when the temperature goes above 60 degree, there will be irreversible nerve damage, which will present in the form of permanent injury. However, when we go lower on the temperature side, 10 to -20, again there will be neuropraxia. -20 to -100, reversible cryoneurolysis, and below -100, there will be irreversible damage. So when you see the safety margin on the either side, on the higher side, when we use the heat-based ablation modalities, we have the safety margin of only 15 degrees Celsius. But when we go on the lower side, we have enough 100 degree Celsius to play with the nerve. So that's why when it comes to ablating the areas which are very close to the nerve, you should always choose the cryoablation modality over any kind of heat-based modality. So before jumping into the case, you have to always plan the case, map out the anatomy, use multiple imaging modalities to map out the nerve and relation of it with the area of ablation. Again, against the heat or cold-based modality, always give preference to the cold-based modality. If possible, you can always use a non-thermal IRE. That is also another option. Coming to the approach, you should always avoid the nerve in the area of trajectory. And again, when you map the area of ablation, the area of ablation should not come into contact with the area of the nerve. Again, we have multiple protective techniques to use, and I will be coming up into the subsequent slides. So this is a very interesting article from RSNA, which will tell you the anatomy of the nerve in relation to the multiple critical areas. So we have multiple MSK tumors in the shoulder area, pelvic area, and this article will give you the good information about the neuroanatomy. Our plan, we usually do MRI neurography if the nerve tumors are lying in critical locations. So this was a case of osteoblastoma. We did the MRI neurography. You will see the C6 nerve root just wrapping around the antral aspect of the tumor. That was a fibromatosis case, encased on the anterolateral side by the sciatic nerve. So we do document all the cases with the baseline nerve conduction study, because many of the patients will not have the clinical presentation in the form of sensory or motor loss. So it is always good to document the baseline nerve deficit so that if the patient comes later on with the nerve conduction report, you have some baseline study to compete with. Again, during procedure, it is important to map out the area. You can map out with the help of needles or with the help of surface markings. That will give you the conscious sensation that the nerve is lying in that area, and you will not miss out this area. Again, consent is very important. Always explain all these things to the patient before taking the case. Always give the possibility of what will be the symptoms of sensory or motor neurodeficit in the area where you are playing with the nerve. So there are multiple strategies. It can be either passive, active, or mitigation. Coming to the passive protection, where we actually don't do any active intervention, we just monitor the physiologic imaging and temperature parameters around the nerve, so that we will just get to know what will be the temperature around the important critical structures. So biofeedback is a most common and basic technique which we use. So here we keep the patient in conscious alert sedation. We tell the patient to get the biofeedback from the patient in the form of either sensory or motor. Here it is critical to avoid the local anesthesia, because that will mix up your results of ablation with the help of lignocaine. So always avoid the local anesthesia, and when you encounter any kind of deficit, either sensory or motor, always adjust the geometry of the ablation, or you can terminate the ablation. So coming to the second strategy, here we use thin, small 22 to 27 gauge thermocouple probes. We keep this probe adjacent to the area of ablation. These probes can be combined with the ablative device, or we can keep them separately away from the area of ablation. Since they are very small, it gives us the flexibility of using them as a coaxially, so that the same needle can be used as a hydrodissection, and through the same needle we can put the thin thermocouples. So always essential to place these thermoneedles in the area where you are expecting some critical structure. So this was a case where the tibial osteoblastoma was ablated with the help of RFA. However, you can see the deep peroneal was in close vicinity to the area of ablation, and here the author used the thermocouple to monitor the temperature around the nerve. Coming to another passive strategy, when you use cryoablation, you have to always monitor the margin of the ice ball that corresponds to the 0 degree temperature. So visualization is always easier when the tumor is in the soft tissue or in fluid or in the lytic tumors, but it becomes a challenge when you monitor this ice ball in the bony areas. You keep the buffer of approximately 5 to 10 mm between the ice edge margin, which is 0 degree area, with respect to the nerve. So this was a case, 27-year-old female, left femur condyle lytic lesion, presented with pain score of 7 out of 10. We planned for cryoablation, so we did the biopsy and ablation in the same setting. So biopsy turned out to be the chondroblastoma. The lesion was lighting up on the PET scan. So this was how the needle was packed, cryo needle was packed to the same Murphy bone biopsy needle. The main challenge was the sciatic nerve was in the close vicinity. So you can use the subtracted CT images. You can subtract the image of the cryo with respect to your baseline image, and you will see some sort of white area of ice ball reaching to the sciatic nerve, and this was the result. The patient was pain-free. Again, if you have the facility of using dual energy CT scan, you can convert such kind of raw images with the beautiful images where you will see there is reduction in the artifacts from the cryoprobes also, and when there is a challenge to visualize ice balls in the fatty area, you will have good confidence in getting the ablative margin. Again, passive strategy, not most commonly used, mostly used by the surgeons. It is intraoperative neuromonitoring. You need the good dedicated team consisting of the neurophysician, anesthetist, and technician, where you can either monitor sensory, motor, or EMG. So in sensory, you can give the cortical stimulation and measure the peripheral areas, or it's a vice versa. So not commonly used by IR peoples. These are most commonly used by the neurosurgeons. So coming to the active protection, here we do some active intervention to physically separate the area of thermal ablation from the critical structures like nerve. So basic modality hydrodissection, where we use the saline or D5 to protect the thermal area from the nerve. So the safety margin, what we say is at least we have to keep the distance of 1 centimeter between the area of ablation and the nerve. So for this hydrodissection, we can use standard Quincke needle or blunt tip stylet or blunt tip catheter. So the good thing is that the hydrodissection can be visualized on all the conventional modalities like CT scan, ultrasound. When you are using CT scan, it is wise to mix the fluid with the help of iodinated contrast, which will give again good confidence and distribution of the contrast. Again, here we are not just doing the physical displacement. You can play with the temperature. So when you are doing cryoablations, you can use the warm saline, and when you are using the heat-based modalities, you can use the cold saline. So this was a 14-year-old female, case of right foot vascular malformation, already underwent 5 sessions of sclero. Now you can see whatever left is a interstitial soft tissue, no areas of cystic channel to do the further sessions of sclerotherapy. Patient had again a residual pain of 4 out of 10. Biopsy turned out to be a vascular malformation. We do biopsy just to get to know about what is the genetics involving all this vascular malformation. The main critical structure was the median plantar nerve, which was lying in the superficial area. So this is how the cryo was done, covering from the posterior to the anterior. 3 ablation zones were done. However, to protect the medial plantar nerve, we did the active hydrodissection. You can see how the ice ball has blunted from the inferior aspect and how sharp the margin is on the superior aspect. So you can see the good amount of hydrodissection on the plantar aspect, and this patient was very much fine. You can see on the follow-up scan, intervascularity has gone and patient was pain-free. However, on the next day, when we do the clinical examination, we came to know that this was the right area where we did the treatment. However, on the left side, the patient was having the symptoms of foot drop. So what went wrong when we critically analyzed the case? This was the position given to the patient while doing cryoablation. So left leg was flexed at knee area, and it was kept under the area of right foot where we were doing ablation. So this was a critical area where pressure built up during the procedure over the period of 2 to 3 hours, and there was a compression of common peroneal nerve against the fibular head. So this again, patient developed the symptoms of neuropraxia in the form of foot drop. However, the patient get away with all the symptoms of neuropraxia with the help of conservative management in the form of prednisolone, physiotherapy, and the foot drop, and ultimately patient recovered after one month. Again, you can do pneumodissection. Here, either you can use the CO2 or room air. Air is a good barrier if you compare with the water, so it is 10 times much more effective. CO2 is preferred over the room air because it has a high blood solubility, lower embolism risk, even if it goes inside the blood vessel, and it is less painful as compared to air. Since it's a lighter, it will have a tendency to go into the non-dependent anatomy, and since air is a barrier for the ultrasound, all these cases has to be done under CT guidance. So this was a case of L3 pedicle osteoderma lighting up on the PET scan. The challenge was here, it was very close to the spine. So we gave the position to the patient in such a way that the area of ablation will be in the non-dependent position. We reached the tumor with the help of bone biopsy needle through which the RFA electrode was passed. Epidural catheter was placed through which the air was infused, and you can see the good amount of separation between the spinal cord and the area of ablation. And on the follow-up, the patient was pain-free, and area was not showing any uptake on the PET scan. Hydroconvection, here sometimes we will see cases where there will be challenge in doing hydrodissection because the area will be too small and we have to inject a good amount of hydrodissection because the cryoablation will go on at least for 1 hour. So here, because of such challenging situations, we can use the continuous infusion of the fluid. According to the modality, you can play around with the temperature of the fluid. So this was a case of papillary carcinoma of thyroid post-surgery and EBRT. The bed was full of adhesions and everything. So there was a bedal recurrence. The tumor was lying close to the trachea also and a recurrent laryngeal nerve. So here we use the moving shot technique. However, because of post-op area and post-RT, there was multiple adhesions and tumor was not getting separated from trachea. So we did the continuous infusion of the fluid during ablation. This is how hydroconvection can be done. And on post-RFA, you can see the area has become non-avid. Coming to the fourth strategy, you can do the physical displacement either with the help of different patient positioning. Some RFA has an expandable tank, so once you anchor the RFA or with the help of stick mode, you can adhere the cryo probe to the lesion. You can just play around with the needle. You can pull, push, or angulate the needle so that you can separate out the nerve from the area of ablation. Again, so some people have used balloon interposition between the nerve and the area of ablation, and balloon can be inflated either with the gas or fluids. So this was a case where the tumor was close to the brachial plexus in arms down position. When we do arms up, the brachial plexus is now away from the area of ablation. This was case taken from the internet. Here the area of ablation was close to the S3. Here author used the angioplasty balloon just to separate the tumor from the right S3 nerve tumor. And again, to protect the skin, subcutaneous pneumodissection was done to protect for skin protection. Coming to the last modality, mitigation, where you can do, once you know that nerve injury has happened or when you're having the critical nerve location, you can do prophylactic or responsive strategies to prevent the nerve injury. So here, the IV steroids are the mainstay, which can be used either as a prophylactic or responsive or direct application. So you can inject steroids directly inside the nerve area. And the response takes some time, so it usually takes around 6 months to get away with this all the injuries. So in conclusion, we have multiple modalities to use away. So it can be either active protection or passive protection, and according to the case, you have to take the call which one to use. Thank you.
Thank you everyone for
Thank you, sir.
We are, I think, running out of time already. Will we be able to finish the debate, the last one? Okay, so quickly. Yeah.
Thank you, Dr. Suraj, for the insightful discussion. Next, we call upon on stage Dr. Satish Ramamurthy to moderate the debate between Dr. Balaji Kola sir and Dr. Ajit Yadav on a very interesting topic, which is, should IR be a subspecialty or a skill set? Where is...
You already lost. So we can collectively answer for him, perhaps.
I'll just call sir once. Just a couple of minutes. I'll just check where Dr. Ajit Yadav is also.
Yeah. So yeah, I think Ajit is on the way. So Balaji, you're going to go first? Okay.
Dr. Ajit, you are late.
Okay, good. So that's a good strategy to win a debate. So yeah. So I think it's an interesting topic. I was told to introduce the topic a little bit and then get them to do their punchings. So we are all facing these so-called, the challenges we're facing is global. It's not just local, but we have some local specific issues, and I hope the speakers will touch upon those. So the debate is it a subspecialty or is it a skill set? Isn't it? Yeah. So who's going to talk about, Balaji is going to go first and he's going to talk about that it is a skill set. It's a subspecialty. Yeah.
Skill set.
Skill set. So skill set. We started with skill set, so the most skilled IR will take first.
So fundamentally, interventional radiology is a skill set. It's not a subspecialty. It's not a super specialty. Because the true strength that lies in the technique and decision making and integration across the clinical specialties. It's not that we are a subspecialty. It's like what we are doing. Second thing is not every subspecialty is organ based, like cardiology, nephrology, but we treat every organ. So it's basically a skill set. So we can't say it's a subspecialty or a super specialty. If we treat one organ, definitely we are going to be recognized in the public. But if we are recognized as an interventionist, that means we are a skill set, not a subspecialty. The cardiology that owns heart, neurology owns brain, gastro, GI tract, but IR treat vessel, duct, tumor, bleeding, all across the organ. And IR defined by how, not where. So IR is all about image guidance, catheter navigation, needle-based access, minimal invasive therapy, and these techniques apply to liver, uterus, anything. So these are all the definition of a skill set. If you put these on AI, this is going to give you, this is skill set. This is not a specialty, this is not a modality. It's a skill set. And how? So the approach-based disciplines are skill platform, not the silos. Like endoscopy, laparoscopy, robotic surgery, ultrasound-guided procedures, all these are not related with one specialty. If you said me, the endoscopy, surgeon also doing. Laparoscopy, everyone is doing. Robotic thing, everyone is doing. So intervention, similarly, we are also doing. The neurologist also doing. The cardiologist also doing. Even GI surgeons also doing. So it's a skill set. So everyone can learn that skill and can start practicing. Even nowadays, even neurologists and neurosurgeons are doing more stroke than us, the more coiling than us. So what is it? The skill set can be developed by anyone. So we can't call it as a subspecialty or a super specialty. The training can be modular or competency based. Competency matter more than the credentials. So skill can be taught via fellowship, modular certification, simulation based training. A radiologist, surgeon, cardiologist, anyone can do image guided, catheter competent and outcome accountable. If IR were a subspecialty, it would have one organ identified. Subspecialty must have a home organ, IR has none. And that is the strength. There is no IR ward in one organ. No single disease spectrum, no exclusion of population, because IR exists because skills are universally applicable. And that's my thing. Interventional radiology is not diminished by a skill set, it is empowered by it. So we are proud that we are having that skill set.
Thank you. Thank you, Dr. Ajit.
Once they both are done, then. While he's going over it, Ajit, do you want to work under radiology all your life? We will talk.
Hi, I'm Dr. Balaji Patel, and I'm going to defend that intervention radiology is not merely a skill set, but it's a subspecialty. Because, anybody who has a skill to hold the needle doesn't become an intervention radiologist. We should know where to poke, and after poking, how to do the procedure, how to manage the complication. A lot of other things are there. It's not just to poke the needle and you have the skill and you become an intervention radiologist. So intervention radiology is formally recognized by the best boards across the world, and we have a curriculum. So a National Medical Council or American board, we have a curriculum saying that, you have to go through this and then you become an intervention radiologist. It's not that you learn a small procedure like, PTBD, you are counted as intervention radiologist. So as I said, it's not just doing a procedure, but, you have to become clinical expertise where you are exposed to how to do the procedure, how to manage, all the complications and the peri-procedural pharmacology, your follow-up, all these includes. And it's not just doing a skill set of a small procedure, but to manage the entire patient and his disease. So in the same way, we are very independent, we are not a service provider. You should understand that we are not still a service provider, but we are taking our independent decision. Once the patient comes under IR, We are going to decide whether we are going to do this procedure or not. And if you're doing this procedure, which modality you're going to use. It is not being referred by some gynecologist and saying that you have to do this. No, they refer the disease and we take a call and we manage the patient completely and we cure the disease. So it cannot be a simple skill set. It's complete subspecialty. So as an IR, like, a distinct body of knowledge, like he said that, you don't have an organ. We have the entire human being. Okay, it's not the organ. Like, we have the biggest playground as human body. So we manage everything. We should be proud that we are not limited to a simple organ. We can cure everything anywhere. So we have, we are the best to do this because we are basically radiologists. So we know that, what is the cross-sectional imaging. We know the vascular physiology, and we know the oncology, biology. Then we know what are the embolic material science. We know it, where to use, what to use. We know all the devices, if you're doing, embolization, whether to use cryo, whether to use reversible glass puta dekho. So, we are the people to decide what, where, how. So you cannot say that it's a simple skill set. You cannot say that I know how to drive a car, let me drive the flight. Both are called drivers. No, it is not possible. So, you cannot say that somebody has learned how to put a catheter somewhere like in heart. He cannot go into brain and do embolization. He has to know a lot of other things. You cannot be an extension of urology if you're doing a PA. You cannot be extension of oncology if you're doing any taste. So it is all a subspecialty where you are managing the entire disease. You are independent and you take a decision by your own self. Now intervention radiology has grown so much that you are owning the disease. From the selection of the patient, to the treatment, to the follow-up, everything is done by the intervention radiology. So it is not merely a skill set that somebody has referred you a patient and you just do the procedure and you're giving back the patient. No. You are owning the procedure. You're owning everything, the complications. It is not just doing the procedure, as I said. You have to know where the complications can occur, how to avoid, and if happens, how to manage them. It is not a mere skill set. And as I said, patients are referred to IR for a service, okay? It is not that they don't think that you can do this procedure. They know that you can manage the entire disease. So we are passing through the, thing, all these specialties which are now being called as subspecialty, like cardiology was once called as service of medicine. Anesthesia was just like a support. And radiology itself is called diagnostic assistance. In the same way, IR is evolving now as a subspecialty. People will recognize it very soon. Thank you.
Thank you, Balaji, and thank you.
The format is that now there is some time for rebuttal. Yeah. So disclaimers, no violence allowed. So Ajit, you can come and give him some.
Lost one bottle, so that's
yeah. So next is it's still there.
Excellent talk, Dr. Ajit.
No.
So I think Balaji told a lot of things. It's a human body. Yes, we treat a human body. Nobody says a veterinary IR. So yes, the thing is, whenever we have a skill set, whether in your hospital, with the turf erosion only arise in few of the branches of medicine. One of this is intervention radiology. And another one is where is laparoscopy and robotics come. There is no other branch. You can't do anesthesia. You can't do cardiology. You can't do nephrology. But they can do. They can make a fistula because it's a skill set. They can do angioplasty because it's a skill set. Neurologist can do the stroke because it's a skill set. And you say, IR, we refer the patient to IR. How? If there is a vascular surgeon in your department, the patient is going to send to the vascular surgeon because he can do the arterial, he can do the endovascular stenting. If there is IR, patient will be divided between two. But if there is a cardiology department, the patient is not going to divide between the medicine and the cardiology because they have a subspecialty and you have a skill set. That skill set is divided into two branches. And then it's going to divide into three branches, patient is going to divide between three. So how you can say it's a super specialty or it's a subspecialty? Patient come to you and they never ask you who you are. He's going to, can you treat me by any means minimal invasive without surgery? Vascular surgeon, you are endosurgeon. If he comes to you for a thyroid ablation, he don't know about you. He know you can do that particularly with a needle. Needle is a skill set. The patient does not know about the IR. He search the internet for microablation of thyroid nodule. Any surgeon can like do the PR-ship. Me also can do, he also can do, even the person sitting there, he also can do that. If he has that skill set, patient is going to have faith in the person who can do it safely. So, skill set means safety of the patient, not related with subspecialty.
Thank you. Thanks.
So I think we need to rename this debate as bipolar debate. So we are all in depression now. So he is now going to take us into mania. Balaji, your rebuttal.
So in any scenario, like, if you are a medical doctor, that means you are entitled to do anything of your body, okay? That doesn't mean that, what do you say, a gynecologist wants to do a uterine artery embolization. Yes, if they learn in a proper way, they can do it. And as you said, like, patient go to them. But intervention radiology, because as I said, because it's called as a subspecialty where you are learning the imaging and then how you want to treat, how big is the lesion, what is the best modality, what is all the embolizing material, everything, you have better knowledge as a package, okay? When you have a better knowledge, then you have become the best. It is in MBBS, you have learned all the surgery things. Don't you think patient come to you for surgery? But you have chosen a subspecialty to treat these diseases. Yes, if somebody is trained in stroke or anywhere, they want to do it. But as the awareness is growing, now the patient also is coming for an intervention radiologist because they have recognized that we are the best specialty to do these minimally invasive endovascular or these percutaneous procedures. It is evolving. I'm sure that it is evolving. There's a lot of advertising or awareness programs going on in the morning. If you have come, we have done a walkathon where the patients have come and they were so thankful, because they didn't want a surgery. They came directly to a intervention radiologist to save their uterus. They told by themselves, this is the change what we are seeing already, and this is going to increase. Believe me, it is going to increase. And yeah, when I'll just talk about 16 years back when I was a fellow in KEM, when a patient comes with a neuroaneurysm, it was allowed to a neurosurgeon and an intervention radiologist to go and talk to the patient. That is the difference what we are going to get in near future. And as all things, we are coming with IR hospitals where IR will be given as a priority, and we will advertise to the patient saying that we are the best to do these minimally invasive procedures. It will take time, but it is evolving. It will come soon.
Thank you. Thank you. Thank you, Balaji. So I see a couple of people Franco wants to say something.
Yeah, I think there are a lot of valid points. So yeah, I'm sure we all have lots to say. This can go on over some more enrichment also, but yeah.
Franco,
sorry, I just wanted to.
I would like to thank you because you woke me up by my jet lag. So, I mean, who is a radiation therapist? Is a subspecialty or is a skill set? A radiation therapist. Okay. So this is what I mean. So we are just playing the field at our infancy age. You have to think about that 60 years ago, there were no liver surgeons, there were no urologists, there were just surgeons. Nowadays, they have liver surgeons, they are cardiac surgeons. So we are just at the beginning of our life. So in my feeling is that we are a specialty, not a subspecialty, based on skill set.
Yeah.
Yes.
And in the future, we will have some subspecialty. Neuro-interventional radiologists, liver interventional radiologists, onco-interventional radiologists. But we are specialties. That's my feeling.
That's a very good point.
Once he's done.
Yeah.
Once he's done, I'll corroborate a little bit historically.
I'll give you a real life example of why it should not be a skill set in my example. So a lot of gynecologists, they want to practice uterine microwave ablation. And they might go to the best centers in the world and train with the best mentors, but they don't know what their mentors went through. It's like a 30 years journey, and then they became that one. Just a few days training or a month of attachment, and without understanding the ultrasound, without understanding the MRI, we have seen uterine artery being exploded and then they're being sent to us. Whereas for us, when we do thyroid ablation, before we go into thyroid ablation, we have done hundreds of FNACs, chemical ablations of goiter, and then only we moved on to, So I get the point that specialty is, but I think the message is we have to be more visible. We have to go to the patient. We have to bypass everybody.
Yeah.
I think that is...
I think one other point which adds to what you said is I have my personal experience. When I first started 12, 15 years ago in the center where I'm working now, and I had, because we shared the labs with the cardiologist. So the cardiologist was sitting there, we were talking about, the cardiologist's exact words were, I put the wire into the heart, I can put it anywhere. That's exactly what he said. My rebuttal was, I put the wire anywhere, I can put it in the heart. If I can put it anywhere, of course I can put it in the heart. So it cuts both ways. The specialization part of it. So Arun, yeah.
All the things that are sent that again come to the skill set.
Yes.
You
Yes.
talked about the ablation of the gynecologist.
Of course. Yeah.
You said that she has taken 1 month, 2 months training, so she has not developed the skill set. So any person who can develop the skill set has the ability to do the procedure. Patient will thank the doctor because you are intervention radiologist. Whoever treats him, the patient will thank him.
So
I just want to emphasize on the fact you are correct. Ajit is also correct. We have a skill set. But let's go back about 70, 80 years ago. Anybody who has a cancer right now, where do they go? They go to an oncologist. You know who was the first biggest oncologist in the US? He was a pathologist, Sidney Farber. Dana-Farber Cancer Institute got formed by him. He was a pathologist. I just read a book on him last week and I was shocked. Then you start understanding how the philosophy of a field works out. What you're saying is correct. We are on a journey. When you look from the 30,000-foot view, you see, okay, fine, we are in infancy. If this is the problem that you just want to be a skill set, not a specialty, why did oncology separate itself out from everything else? Then surgery came to being. Surgery, then medicine. Medicine's biggest cutout was cardiology. And now we vehemently accept that cardiology is a specialty. Go to 50s, there was no cardiology. And then now go back to radiology. Radiation oncology, their biggest conference is RSNA. Yeah. RSNA is a radiology conference. Why? Because they got out of that. So what I'm trying to say is, again, a different angle to it. We understand it's a skill set, and that's how a specialty is made. But the natural evolution is a subspecialty desire, and that's what we get. In the US, we have achieved it. The rest of the world is going towards it. I know both of you agree with that fact. You're just debating for the sake of debating.
That is true.
We all want freedom.
Yeah.
The freedom comes from the fact that we are accepted as a specialty.
No. So the thing is,
I think
if I am saying if this debate is I'm in the Ukraine praising the Russia because all of you are intervention radiologists here and you want to oppose me anyhow, and I am the only person sitting I am fighting for the thing that I really don't want to accept. But still, the topic was given me to Mukta, and he said, "Sir, you have to be prepared for that." And I said, "No, other person
Mukta, you have to give her dinner.
Other person has to convince me. I can convince him anyhow. I know I will talking against my own."
Yes.
Again, my own specialty. But we have an infant, but still we didn't give him a name.
Yeah.
So definitely we are having an infant, but we have to give him a name as infant as an intervention radiology.
No, Franco answered that really beautifully.
Yeah.
That we are a specialty.
So it's a specialty.
Specialty based on skill.
I agree with Dr. Franco, but not on this platform.
Yeah. And I'll make a point. See, Dr. Franco, he made a comparison to radiation oncology. Mukta sprung this on to me yesterday and said that you are now the moderator for this. So I've been thinking about it. I think the closest specialty from which we can learn something is actually plastic surgery. Patients go to a plastic surgeon directly unless they want their nose fixed or things like that? Forget cosmetic surgery. Cosmetic surgery in plastic surgery is less than 20% of their practice. 80% of their practice is rotational flap. Patients and things like that. Patients don't go to them saying that I want a flap. But they are, we will not debate with them saying plastic surgery is not a specialty, right? It is a specialty which is based on a skill. So if we have to learn our lessons, we have to look at plastic surgery. Now, plastic surgeons are like us. They are referral based. They are always like this. They are never like this. So we are also like this. But having said that, we do have our own things like PAE, UFE, thyroid ablations, where we can go to the patients, like how they would go to Botox, whatever. You know, most of you would have used their services. So yeah, so something like that. You know, something like that. We'll also have to. It is absolutely brilliant words. We should put on our coat of armor. We are a specialty which is based on skill.
One quick
so now
comment,
both of you hug.
One quick comment. You know, extending what he said, when humans, all of us, when we are conceived, we are unicellular. We keep dividing, and then we differentiate into different organs. That's how we evolve. That's how we mature. I think we are not at the conception stage for sure. We are a well-formed, maybe an infant, newborn, whatever you want to say, and it's certain that we are already evolving. And there is no question that we have to be very skilled technically to become an interventional radiologist. But is that enough? I know Ajit, I know his practice, that's not enough. He is one of the biggest advocates of pulling patients to their own practice, and he's doing it in many ways. So, and does it stop there, just bringing patients and doing this? Or you want to become somebody like Franco, Dr. Govindarajan, Dr. Riyad Salim, where they have really gone deep and understood the biology of disease, done animal experiments. So that is where we probably are headed. There are many issues and we don't have the infrastructure, things like that. So everyone, everywhere cannot be as evolved as these people are. But for sure, we all are technically skilled. That is our basic requirement. And so Ajit is where is our basic requirement. Balaji is where we are all wanting to. That's, I think.
So Aniruddha has become Gautama. Aniruddha's answer is so zen. We should call him Gautama now. No more Aniruddha. Very zen.
So the concept of the debate is whether if somebody develops the skill set is allowed to do the procedure. Yeah. That is the basic.
Absolutely. So I think we have made the right step in doing a DM and DRNB for that.
Correct.
Because plastic surgery previously was, many of them, like if you take the transplant surgeons, previously the anastomosis used to be done by vascular surgeons. Now which transplant surgeon calls a vascular surgeon to come and do the anastomosis? So now the vascular surgeons cannot do transplant, they cannot do peripheral, they cannot do aorta. What are they going to do? So the same thing we will also face. So our first step is to legitimize. So now if we go and talk to a urologist who wants to do a PAE or a gynecologist who wants to do a EFE, we can say that we have a curriculum who are officially trained, like this cardiologist who told me, I can put a wire, I can put anywhere. We can say, no, you can't because we have been doing this.
Agreed, but will we be able to stop anyone if he or she has developed a skill set to
of course.
Stop a procedure?
I guess, yes, 100%. 100%. No.
You cannot.
No, not at present, okay? Like that's why I said peripheral and aorta is almost gone. But if you want to keep the PAE and UFEs and my vascular surgeon wants to do TIPS and portal thrombosis, thrombectomies. He wants me to come and give the puncture and give access to him in portal vein, and then he will do thrombectomy. I said some choice words.
If he has a skill set, anyone can in the hospital or the society or anything can stop him?
Yes. No, now we can. Now we have a curriculum to do it.
Nobody can stop.
No, I'm sure they can stop in the US, right? No, neurosurgery, right, it is probably again gone. But we have all been sleeping till now. Now we have woken up. Now we can at least stop from now on. That's my point.
He already
yes, of course. Yeah, it's global. That is global.
Everything is a continuum. Nothing is like plus 0 or 1. What he mentioned, like this will always happen. This happened in the US also. But slowly with the accreditation, legitimization, all the consulting and everything, and with the legal work, we have reached to a point that if somebody else does it, they have to get accreditation from our society, from our systems. And that's where it's all evolutionary. So I understand your problem here. Here, like it's kind of a Wild West, which we used to say like in the 60s in the US. Now, we have a very, very schematic system. That's where you're heading, and he mentioned that, like you guys have already thought of it. That's the only way to defend your
So that's what is happening in the US. All the procedures you mentioned, it is the same in the US and Europe as well. Vascular surgeons doing peripheral, but vascular surgeons there are not wanting to do PAE.
Want to see, be
right?
the change you want to see in others.
Just to
Not
defend
wait.
it, like,
you are the leader, Arun. You are the leader. You can't say that we were waiting. You have to lead.
One of the famous urologists in Hyderabad, he
Yeah.
attempted doing a PAE. Okay, he on a live workshop, he embolized a muscular branch, and he's showing the urologist that it's a prostate. And to the greatness of this guy, like, he's telling that he's going to do a live workshop.
No, Balaji, one second. If he had done the prostate artery properly, would you say that's okay? No. So I don't think we should throw stones. So there is no point. There is no point whether he did it right or not. Okay, that is not the point. That besides the point. The point is, should he be doing it or not? Has he got a legitimacy to do it? That is where our body comes in. Now we have a DM and DNRB. We can say that we have people who have been trained in this. Doesn't matter whether you do it right or wrong, you just are not allowed to do it. Now we have legitimacy, right? You go to a court of law, the law is going to ask what God-given right have you got to do PA and why shouldn't he do it? Now we can say we do because we have a curriculum.
We have defended. No, we have defended in the same way.
Yeah.
We have took out the entire curriculum of urology. We have took down the entire curriculum of radiology, interventional radiology, and we showed them who is supposed to do.
Yes, that's a good
And then we
approach.
won it.
Because we know that we have failed by throwing stones at vascular surgeons.
Someone from our specialty should go for an MP. And the ministry.
That's true.
I second Ajit. I second Ajit.
And I know who's the happy person in this society now in this room is Mukta. इसका काम हो गया. इसने तो लड़ाई करवाने की करवा दी. She is the most happy person.
But can I have a raise of hand?
Such kind of debate.
Can we have a raise of hand amongst us? Who do you think should be the MPB? It is undoubtedly Dr. We have the answer.
And I even chosen a mascot for him, which I'll tell after a while.
They're owning the disease, and that's where we are heading. We are almost there. Like, ablation-wise, we are really doing good.
Yeah.
Prostate-wise, we are doing really good. We understand the physiology. So that's how we will win. So we have the skill set, we accept where we are, we move where we want to be, and we own the disease in a clinical sense. Yes, you cannot just do the procedure and run away. That's when we become a skill set, become a mechanic. You be the owner rather than the mechanic.
Also, the stuff I think we are very close to it, so it looks very big. Because the stuff are in all specialties. You go to the plastic surgeons, they crib about ENT surgeons doing something. The ENT surgeons crib about plastic surgeons coming and removing cysts. Every specialty, nobody is happy.
It's a human behavior.
It is a human behavior.
Yeah, it's a human thing.
So I think
it's
if
not a specialty thing.
Exactly. So I think if we step back, we have achieved quite a lot. Anyway, I think it's getting quite late, so yeah, sorry.
Yeah, one comment. So we are not the only ones forming DMs and forming curriculums. The Nephrology Society, for example, has formed a curriculum where they say that fistuloplasty is
correct.
We are doing fistuloplasty and creation of fistulas. I know nephrologists
have
done thousands of fistulas.
Yes.
And by that example, they have written to the boards, and these are all evolving. Nothing is ours. Everything is.
No, that's what I'm saying. Everybody wants to put their hand in others' pockets, and we should be doing the same.
So last comment ये है, अपना बच्चा और दूसरे की बीवी सबको अच्छी लगती है.
To answer this,
so ऐसे specialty के दूसरों में लड़ाई करते रहे.
Ajit, the nephrology question. We have 11 rooms running at any point. We have one room is specifically for fistula work, and that's run by a nephrologist who comes to our system and works. There's enough work here, more than enough work.
Should have been done on the main. No, this is a hot topic. Yeah, even in the US because. Yes.
फोन से भी लेगा बोल भी दे भाई हाँ